Rosanna.
हेलो
तुम एक बार शेयर करो। एक बार शेयर करके देखो।
Is it coming? Is it coming?
Yes, it's coming.
Okay, I'm just putting a full screen.
Yeah, slide share कर दो। ठीक है, I'm
Why is coming this tung tung tung? I'm gonna start there actually.
ठीक है, तुम लॉग ऑफ कर सकते हो। स्टॉप स्क्रीन शेयर। फर्स्ट प्रज्ञा विल से नहीं, इन्हें दिया से।
Sansita, but you just speak something, no? Because when you speak, na, there is some sound is coming from there.
Are you listening now?
It's echoing actually.
Just wait, check, huh? What about now?
Yeah, now it's fine.
Now it's fine, na? Okay.
Yeah.
I've actually just left the meeting from this laptop. So now it's good, na?
Yeah.
Okay, fine. So first, Pragya will start.
Okay.
Then you carry on with this one, audiology and clinical part.
Yes.
Then after that, I'll continue with the radiology part, okay? Good morning, Pukon sir. Sir, good to see you. Sir, mute हो ऐसे. Pukon sir, you're muted.
I was very good morning to you all, actually.
Good morning, sir.
Rosina, you have got also presentation today, and Sanchita
Yes.
also. Very nice.
Yes, sir.
Sir, good morning.
Good morning, Bisha.
How is the sound, sir?
Huh?
Sound কেনেকুৱা? Sound কেনেকুৱা?
Sound ঠিক আছে?
আজি বেলেগ নাৰী ভুৰি লগাইছে মোৰ মাথা ঘূৰাই গৈছে. So from the OT, বেলেগ wiring লগাইছে আজি একদম.
হয় নেকি? Overcrowded wiring নি?
একদম মোৰ মাথা ঘূৰাই গৈছে আধা ঘন্টাৰ পৰা. So soundটো ভালে আহি আছে ন? এটা বেলেগ হে ইউজ কৰিছে actually microphone এটা.
তেতিয়া ভাল, soundটো ভাললে ভাল. নহলে বুজি নাপায়তো.
Hi sir. Yes sir. Okay. Pragya hasn't logged in. Okay, now Pragya is logging in. Robbie, admit कर दो और co-host बना दो. Sir, मैं mute हुआ ऐसो हाँ. Pragya, you can also share his photo if you want. I've sent you his photo, na?
Ah,
You can share the photo. Don't share
তুমি ককলে
immediately.
সিআই ককলে ইমপ্লান্ট নোহোৱা নেকি তোমাক লিংক দিছে নহয় নিশ্চয়
Pragya, don't share immediately.
নে পাৰিবা তোমাক মই এতিয়া নতুন নতুন লিংক এটা দিছে মই তোমালে পঠাই দিছো তুমি তুমি হোৱাটছএপত চোৱা নাই ৰাতিপুৱা 7:30 হোৱা নাই এইটো মানে আগৰ জুমৰ সেইটো দিছে 7:30 বুলি তুমি জয়েন কৰিব পাৰিলা তো মুখাৰ্জী
এতিয়া পাৰিছো জয়েন কৰিব
Mukherjee sir, good morning.
গুড মৰ্নিং
মুছটো অলপমান ট্ৰিম কৰিলা দেখোন
অ চুলিও কমাইছো তো
ভেৰি গুড এতিয়া স্মাৰ্ট লাগিছে লাইক এ ফৌজি ভাই
চুলি একদম সৰু কৰি দিছো
চাবা আফগানিস্তানত পঠাই দিবা তেতিয়া
Pragya, get ready. Biswa sir, can we start? Okay, Pragya, you can start.
good morning, everyone. Thank you so much for joining us on this Thursday morning. This is a special one for the Cochlear Implant team of Pratiksha Hospital and Pratiksha Clinic, as this will be our 49th Cochlear Implant surgery, and we are just on the brink of completing our half century or 50th surgery soon. But before we start, let's take a few moments of silence to offer our condolences for the sudden and sad demise of Professor S.J. Datta, former former professor and HOD ENT department at Assam Medical College and Hospital. I'm sure he must have been a beloved mentor and teacher or friend for a lot of our colleagues out there. So let's take a few moments of silence.
Rosina,
Yes.
you can share your slides now.
Okay.
So Rosina will be giving a brief clinical and audiological history.
Hello, I'm so sorry, I just got disconnected. Yeah, hello, can everybody hear me?
Yes.
Yeah, sorry, I just got disconnected. And I think every workshop, it's like a good omen for us. Some or the other technical issue has to happen. Going ahead, I won't take much time. I would invite Rosina. She is the consulting audiologist for the child who is going to be implanted today. So we invite Rosina to present the audiological and clinical presentation of the child. Over to you, Rosina.
Thanks, Pragya. First of all, thanks to Mukherjee sir and Fukan sir for joining us. Yeah, when we decide a child is a candidate for the cochlear implant or not, the audiological profile of the child is a very first thing we have to know, and it's actually must thing we have to know. And yeah, of course, we do see the other profile, but the first thing we do is audiological evaluations. So for today's, the concerned patient is a child of 5 years old child who presented with a hard of hearing with delayed speech and language development. It was a normal term delivery with 2.6 kg birth weight. In history, the mother had varicella at 5 months of gestation. There was no significant natal history. Postnatally, the child had pneumonia and typhoid at 6 months of age. It was also reported that initially the motor development was slightly delayed. Clinical evaluations, including the pediatric ENT, cardiology, ophthalmology, and the psychological report, all are normal. Moving to audiological evaluations, impedance odometry, it is A-type with reflexes absent in both the ear, which suggests the normal middle ear functions in both the ear. OE was referred in both the ear, which suggests the outer ear cell dysfunction. This is the BERA recording from both the ear. As we can see here, there is no response at the 90 dB click. And also for tone budge at the highest level, there is no peak present here for the left ear. And in the right ear at the highest level, that is 120, there see a response in the right ear at 120 tone burst, 500 tone burst. So the impression made was bilateral, severe to profound, congenital sensory neural hearing loss. After the few sessions of auditory training, added audiometry was done. This is the added audiogram. We can see that the red mark is for the right ear and the blue is for the left ear. And as we can clearly see here, the added responses 1K till 4K, it is already out of the speech banana. And also the added responses from both the ear are almost equal, except at the 500 Hertz for the left ear, which is slightly better. Otherwise, all are equal. And these are the speech audiometry, which was done in the detection level for all the link sounds. So based on this audiogram, we can see that the child is not benefiting, has very little help from the hearing aid. So the cochlear implant was recommended. Moving to speech and language evaluations, the child currently communicating with the parents mainly through gestures only. And right now there is no receptive and the expressive vocabulary developed. In developmental history, the speech and language milestone is already late, that is due to the hearing loss. Motor milestone, again, it was initially reported slightly late. Automotor examination is normal. ISD was administered, that is integrated scales of development, and the child current age is 5 years. But as we can see here, the audition age, receptive and expressive age, it's already much below the child's chronological age. Since the child is not having any associated issues, the cognition age is coming around 31 to 36 months, and the pragmatic age is coming at around 16 to 18 months. So the impression made was delayed speech and language, which is secondary to hearing loss. So we have seen all the evaluations. So from all the evaluations, we can clearly see that the child is in very much need for the cochlear implant in both the ears. But as for now, the child is going only for the unilateral implant. So the question is, which ear to implant? If we look up the impedance, BERA, and audiometry, added audiometry, all were almost equal. Like in the impedance also, it was 8, like normal middle ear function in both the ear. BERA, again, severe to profound hearing loss, and added audiometry, it was also almost equal across the frequency, except in the 500, which is slightly better for the left ear. Radiology, again, favorable for both the ear. So based on this evaluations, any ear is preferable for the cochlear implant surgery. The rest factors I will put on the CI surgeon's decision. So this is all about the audiological profile of the child. Moving to which implant and which electrode we are using for today. So we are using the CI422 implant with a slim straight electrode. So as we can see here, the electrode array is very slim and straight. So the few of the technical specifications about this implant and electrodes, it has got 22 half-banded electrode contacts, and the whole active length of this electrode array is 20 mm, and there is a bezel stiffener here. This is mainly to prevent the buckling of the electrodes while inserting, and the apical diameter is around 0.3 mm, and the bezel diameter is 0.6 mm, and the whole weight of the implant is 9.5 gram. It is suitable for both the surgical approach, that is cochleostomy, and or round window approach. It has got 2 white marker, one at 20 mm and one at 25 mm. The tip of the electrode array is very soft. This is mainly to prevent the traumatic insertion. And the MRI compatibility of this implant is 3 Tesla with the magnet removed. Without the magnet removed, it is 1.5 Tesla. So this is all about the technical specifications of the implant. And so which processor we are using with this implant. So we will be using CP802 processor, and this is the processor, how it looks. It is a very robust and reliable processor. It is made from the titanium, strong titanium with the hard plastic. It is IP rated 57 IP57, which mean for the water resistant and able to withstand the high temperature, humidity, and the dust. It is very easy to use. Just on the on button, and we can go live. It also comes with a rechargeable battery apart from the disposable battery, and the sound processor is also serviceable. It has got dual mic, so it actually provides the hearing in all the everyday situations. Yeah, this is all about the processor. Thanks to thank you.
Thank you, Rosina, for a very comprehensive report on the clinical profile of the child, and as well as giving us a detail about the selected cochlear implant and processor. Before we open the forum for discussion, I quickly wanted to know, was any of the audiological or clinical presentation of the child a deciding factor for choosing this particular implant or this particular processor for the team?
So since the child is not having any other associated issues, because like even the radiological is normal in both the ears, so the child is not like anatomically there is no issue. So basically we should go for the if the patient can, we recommend to go for the better sound quality, like speech processor, and also for the like better implant, because as for the radiological evaluations, like everything is normal, so we should go for the best implant, I mean, and also the best processor. But then again, it also depends on the affordability of the patient side also, right? So based on all that factors, we actually have gone for this, we have choose this implant and the processor.
Okay. Definitely, I think it's not just the audiological profile. Radiology plays a very important role when we go for or make the final selection, especially for the internal implant. Also, in this child, I think because she does have some amount of residual hearing or some benefit, even with the hearing aid at lower frequencies.
Yes.
Your choice of slim straight electrode will be helpful in preserving whatever residual hearing she does have at the lower frequency.
Correct.
Okay, is there any other question from the viewers for Rosina so far?
Electrocochleography was done. Electrocochleography. Hello.
Rosina?
Hello. Hello.
Am I audible?
Yes, sir, you are audible.
Can you please repeat?
Electrocochleography was done or not in this case?
It was not done, sir.
The only reason I want to know is whether residual hearing, how much it is there, that will be revealed by electrocochleography. That corresponds to 1 and 2 wave of beta. Of course, as we have seen already, beta has been done, and it doesn't respond in the highest stimulus, even in tone burst as well as in click. So naturally, electrocochleography is also will not be of much use.
So for tone burst, 500 Hz, we could see a response at 120
Maximum,
dB actual, at the maximum, at the max actually, for the right ear. But we could not see in the left ear.
Naturally, same thing we'll find in electrocochleography also. That is the residual hearing the child has actually.
Yes.
Krista sir will almost go for the incision. Pragya, sorry to interrupt. So I think we have to just make a haste. Krista sir is almost about to start the incision.
Okay. All right, then we quickly invite Dr. Sanchita to kindly present the radiological profile of the child.
Yes.
Yeah, switch karo. Switch it. A very good morning to all. Thank you, Fukan sir. Thank you, Mukherjee sir, and thank you, Partho sir, for joining us today. I will quickly walk you through the radiology part. We all know that radiological evaluation is very important for the candidacy criteria as well as for the surgical feasibility. Let me just bring the DICOM software into the screen view. Robbie, can you help me? Switch it. Just check there in the YouTube whether it's not coming yet. Yeah, it's coming. I hope it's visible, the DICOM view.
Yes, yes.
Yes, it is visible.
Okay, so let me first go through the CT scan. This is the axial view of the CT scan, and I would like to go from above downwards. So
Make
the
it full
important-
screen. Make it full screen.
Make it full screen. Is it full screen now?
No, no.
Sanchita, but can you on the speaker view? I think because of that, it's
Yeah, you switch on the speaker view. In the view. Yes. Speaker view is on.
okay. But yours
I think it's full screen now.
not showing. No, it's not showing.
Rosanna, you have to.
Oh, no. Yes. Now it has come.
Okay, okay.
Yeah. You
So
have to change.
going ahead, I will go from superiorly to inferiorly. So as I scroll down, the first thing which I have to look for is the parietal bone thickness on both the sides. So I have to first look for the asterion. I think the asterion is coming into view. That is the suture line between the squamous part of the temporal bone and the parietal bone. So just as the auricle is coming into view, just
But we are not getting the full screen, no?
Oh, sorry, sir. So
We are not getting the full screen. Mukherjee, you are getting?
No, no, no.
No.
not getting this full screen.
I don't know how come Rosina got.
I can
Sorry.
see, but sir,
Anyway, we can see.
I
We
don't
can
know
see.
how.
Anyway, we can see go on.
We can
Otherwise,
see.
it'll be late.
Please go on. Please go on.
Rosanna, you switch off the video. Biswa sir has suggested you just switch off the video, your video part.
Switch on, no?
Switch off.
Okay.
No,
And mute
Sanchita, but your
yourself.
screen is visible. Your screen is visible. It's just the image is not on a full screen view. Your screen is visible. It's just that the image is not on a full screen view, but it is visible.
It is
So
visible.
you can continue also, or probably in your right hand corner, if you click on the upper corner, maybe it will go on full screen.
So as Robbie is trying to troubleshoot this problem, I think I can carry on. If it is
Yeah,
not
you can carry on. It's visible, yes.
okay. So as I was saying, the asterion is just visible here, and we have to look for the parietal bone thickness here. So I'm focusing first more on the right side. If we can also measure this thickness. So it's quite an adequate thickness of parietal bone on the right side. It's 3.92 millimeter, and on the left side, it is almost, yeah, it's 3.89. So it's a good parietal bone thickness. From that point of view, we are quite safe. That is for the implant bed. Second thing which we have to look for is the emissary vein. Sometimes it's quite prominent and it might pose some difficulty during the posterior superior flap elevation. So from that point of view also, I think we are safe on both the sides. Then we can see the cellularity of the mastoid coming into view. First, I'm focusing on the right side. So let me just magnify the right side. Okay. So we can see that it's a good cellular mastoid on the right side. And we can just view the superior semicircular canal. Tracing down, the posterior semicircular canal is coming into view, and we can see the whole cellularity of the mastoid bone here. Sometimes even the cornus septum is visible. Tracing down, we can see the internal auditory canal coming into view. And a point to note is that anything which is anterior to the internal auditory canal is the cochlea, and the vestibule and the semicircular canal is lying just posterior to the internal auditory meatus. We can see the posterior semicircular canal coming into view. And now the typical signet ring appearance of the lateral semicircular canal. Now here there are certain things to note. One is the diameter of the internal auditory canal. We can measure this. We're supposed to measure it at the midpoint. It is almost 3.83. That's a good diameter. Then the next thing which we have to note is the cochlear aperture. So let me just magnify it a little bit more. So the cochlear aperture here, the diameter is almost 1.67. So that's a good diameter again. Also, we can see the 3 turns of the cochlea coming into view, the interscalar septum. And as we just, the next important thing to note is the track of the facial nerve. So we can see that the facial nerve is coming into view, the labyrinthine portion. The typical bird beak sign is appearing here. This is the GSPN, greater superficial petrosal nerve. And this is the tympanic portion of the facial nerve coming into view. Also, we can see the 2 ossicles in the epitympanum, the malleus and the incus. Now we have to trace this horizontal portion of the facial nerve. If we trace it further, this is the facial nerve, this is the facial nerve. Here, one thing to note is the ice cream cone appearance. So this, we see that it's a good middle ear cavity with good aeration, and we see the incus at the malleus assembly intact. This is the facial nerve again on the right side. Tracing it further down, 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 and here we can see the oval window. This is the stapes. So this is the oval window. Going a bit down again, we can see the round window niche appearing. So this is the point where we have to measure the distance of the facial recess, and also the distance of the facial recess or the facial nerve, the vertical portion, up to the round window niche. This will give us an idea about the surgical feasibility during round window insertion through the facial recess approach. So we can measure this point. We see that the distance of the facial nerve, the vertical portion, up to the annulus is 5.56 millimeter, which is quite good. 3 millimeter is considered to be a good facial recess. And the distance of the facial nerve again up to the round window niche here is 4.24 again. So if it is more than 3 millimeter, it's considered to be a good distance. Now, as the round window started appearing here, we can also note another thing which is of importance, that is the internal carotid artery. So we have to note that there is an adequate thickness of bone between the basal turn of the cochlea and the internal carotid artery. So we can see that there is an adequate thickness of bone here. So we see that the right side is quite favorable from all these, as we have mentioned, all these points. It seems to be a favorable mastoid, favorable middle ear, favorable cochlea, and also favorable in terms of the internal auditory meatus. Also, the jugular bulb, we can note here, it's not high, it's not a high riding jugular bulb. There's no dehiscence noted here. So the right side seems feasible. There are two other things which we need to note. One is the vestibular aqueduct, which is just shown as a dimpling here. It is not enlarged. Also the cochlear aqueduct, which is just noted here, seen as a hairline here. So it is not enlarged again. So the right side is quite feasible again. Let me go to the left side now. Again, coming from superior to inferior. Let me just magnify the left side. Okay, so already I've noted the parietal bone thickness. There is no prominent mastoid emissary vein there, so no trouble with that. Going down, we can see the superior semicircular canal coming into view, good cellularity of the mastoid. Then coming down and down, the posterior semicircular canal coming into view, the internal auditory meatus again. The facial nerve is just started appearing here, the bird beak appearance, GSPN here, the labyrinthine portion, the first genu, the horizontal portion of the facial nerve, then the ossicles coming into view, the typical ice cream cone appearance, the lateral semicircular canal, the typical signet ring appearance again. We see the 3 basal turns of the cochlea coming into view, then the cochlear aperture again, measuring it here, let's see. So it's 1.85 millimeter, which is favorable. Then the internal auditory meatus diameter, that's also 4.52, which is not bad. Then let's trace the facial nerve down, down, down. Here the oval window has started appearing. Again, going down, we can note the round window niche here. So we need to measure the distance here again. Distance from the facial nerve up to the round window niche, which is almost 5.12, which is good. And from the facial nerve up to the annulus, this is the area of the facial recess, which is 4.17, which is again favorable. Now there are 2 other things which we can note in relation to the surgical feasibility. So when we see the round window appearing, let us take one side, that is the right side again. So if we see the round window appearing here, we can draw 2 lines, one tangential to the posterior bony canal and one tangential to the sigmoid sinus. So if we find the basal turn of the cochlea between these 2 lines, then this is considered to be a good indicator as regards to the surgical feasibility to the round window. Second important thing is one line drawn through the posterior bony canal again, another line drawn through the basal turn of the cochlea. So if we see that these 2 lines are not intersecting up to the mid-sagittal plane, then this is considered to be a good feasibility. Again, if we see on the left side, the jugular bulb is not high riding, there is no dehiscence noted. And let's check the round window area again. Yeah, this is the round window and this is the facial nerve. So if we draw a line through the posterior bony canal, another line through the sigmoid sinus area, we see that the round window is between the 2 lines. Let me just speed up because Bisso sir is going too fast. Okay, let me go back. Okay, so regarding the surgical feasibility, as in relation to this CT scan, it is considered quite, both the sides are quite compatible. We can go for any side actually. So let me quickly go through to the MRI part now. The most important MRI is the T2 sequence. Why? Because we need to find a good fluid filled labyrinth, and second, we need to have a good cochlear nerve. So let me just magnify, again going from upward to downwards. Let's check both the sides. So we see a good fluid filled cochlea here and the labyrinth, the semicircular canal and the vestibule. Secondly, if we magnify even more, we can also trace the nerve here. On the left side again, a good fluid filled cochlea. We can note the 3 turns of the cochlea and the semicircular canal and vestibule. Also the nerves are quite evident here. Another important sequence in MRI is the CIS or Fiesta sequence, which is a heavily T2 weighted sequence. Here, if we magnify, the nerves are even more prominent. Let me quickly go to that portion where the nerves are quite prominent. Focusing on the right side, we can very well note the cochlear nerve here. And this is the vestibular portion. So the cochlear vestibular nerve is here and dividing into the cochlear and the vestibular part. On the left side, also there's a good cochlear nerve and the vestibular portion is just dividing here. Next important thing to note is the coronal cut, where we can see the typical snail appearance of the cochlea. You can see all the turns of the cochlea and the labyrinth too. Now the last sequence which is important is the sagittal. The sagittal cut T2 weighted MRI, where we need to note the 4 dot sign. So we can see the 4 dot sign here. One side, this is the right side, and the left side is this one. So we can see 4 dot sign here. So we see that all the 4 nerves are intact. And also we see the 3D imaging here. You can see all the 3 turns of the cochlea and the labyrinth, right side and the left side. Okay, so I will quickly hand over to Biswa sir because he's through his surgery part, and we can take the questions in the midst. Thank you.
Thank you, Sanchita, for a very comprehensive report. I'm sure we would have a few questions on the radiological part, but we can move to Biswajit sir now, and we can, in the meanwhile, we can keep taking questions that you have for Sanchita and going ahead for Biswajit sir as well. The sir has already made the incision, I believe.
On karo. Pooja, good morning.
Hello. Good morning, sir.
Am I audible?
Good morning, sir. Yes, yes, you are audible.
How is the picture there?
Picture is good.
But
It's
not
quite
full screen.
focused. Not full screen.
Ravi will trying for full screen. In the meantime, now it's come. Now it's
No,
come.
this is full. Now it has come, sir. Now it is full screen.
Okay. So this is, have you seen the template? Okay. So thank you,
Yes, sir.
Rosina and Sanchita, for very nice presentation regarding audiological and clinical part of this patient. So I'll go. So you have seen the template of the implant. So ideally, I'm going for the incision part. So this is the Frankfurt line. Can you imagine? This is the outer canthus of the eye. I can palpate the outer canthus of the eye, and it is the imaginary line from that outer canthus of the line to the external auditory canal, center of the external auditory canal, and ultimately where is the processor will sit. That's the matter. So it should be always at the 45 degree. So this is the line. Then again from that line it should be 45 degree. This angle should be 45 degree. So that the idea, this is the part, or in arbitrarily we can sometimes measure the mandible. Where is the mandible? Then that's how we know where finally our disciplinary implant will sit. So I'll go, because here the low hemoglobin, so I'll go little fast. So I'll already injected the site with a xylocan adrenaline, 1:10,000, and this is the incision. Nowadays we go just posterior incision and little curve. And since I have enough time to adrenaline to walk, so mostly can appreciate there is less bleeding. Sister thumb forceps. Thumb forceps. Yeah. 15 smaller name. Mop. I prefer to go with knife rather than diathermy.
So,
Please, Pooja.
right, sir. So, couple of things, like this is before, like not directly related to the step that you are doing right now. But like we check all the audiological factors, we check the radiology. Apart from that, is there any particular thing that you would check? Like for in this case, we are using CP802, the behind the ear processor. So any particular, is there any particular consideration for the thickness of the skin in that area? For any particular processor or in particular implant, do you also measure the thickness of the skin? Is there any way to measure?
Pooja, you are asking me?
Yes.
Pooja?
Yes, yes, sir. Do you usually measure the skin thickness?
Yeah, but this case you see this age of the child is 4+, almost 5. Okay,
Right.
so generally we can get a good flap, good thickness of the skin and muscular thickness layer. And for the juniors, do you know how many layers here before going the final layer? It's almost 5 layers. In that way, this abbreviation is scalp. If you start from skin, chitinous layer that composed of muscles and all the vessels upon loose areolar tissue. So in last the periosteum. So in that way, we get in the older children a good amount of thickness. But it generally we should more concern when you go for younger children. Like if you go for less than 2 years, less than 2 years or less than 1 year child. Suppose a case of meningitis of who have an age of 6 months, or if you go for new criteria of inclusiveness of CI, then you have to concern regarding the thickness of the your flap. And not only this, this also the cortical bone thickness that also matter. That way you can advise the parents which implant receiver implant you will go for the patient. Can you appreciate there is no as such single vessels coming out if you give a time to adrenaline walk. So I'm not putting any diathermy till now, and this is a pure avascular flap. Always expose posteriorly as far as possible, and that way you can.
Bisoda.
Please.
Another question. Good morning. Another question related to the same thing. So, depending on the kind of processor the child would be using, whether the child will be using an off-the-ear processor or behind-the-ear processor.
Yeah.
Would your position? Would you like to change a position?
Yes, a very nice question. Actually, mostly you people have experience regarding the BT and also the distance between BT and the coil now. So that sometimes create problem. But in case of a what the processor is called without the wire.
Single unit processor of the year, yes.
Of the year. If you go then because you see in this side, you have a get more thicker flap if you come towards the mastoid, this region. If you go posteriorly, there's a less thickness. Are you getting that? This when you elevate this flap, you will see there's a more thickness here. Okay, this muscle thickness is there. But if you go posteriorly, so if you use off the ear processor, since BT is not here, because the template, no? Sister. So I am simplifying what Mansi is asking. So this is your BT, na? So you will put your implant here. But if you have a round off the ear processor, so this space is not required. Then definitely I'll more intense to go for the ear bed here, more anteriorly. Then in that way I'll get a very good amount of thickness of my flap for the internal bed. Sure.
Right.
Now knife. So I need a anterior. Already, this is a mastoid tip. This is the external auditory. This is adequate amount of posterior elevation. So this is I am doing for Sansita to close.
So as you continue, we would like to have a discussion on the radiological presentation that Sanchita Ba did. Sanchita Ba, I had a question, like a very basic question. Suppose in this case everything was typical and everything was normal. So suppose when we do come across a deficient cochlear nerve, I mean, is there a particular guideline or is there a particular measurement where you say that this cochlear nerve, even though if it is deficient, we can still go for cochlear implantation, the patient can still benefit from a cochlear implant, versus in a case where we would say that the child will not benefit from a cochlear implant at all, and we probably will have to consider a auditory brainstem implant or other option. Is there any particular guideline or is there any particular measurement that you stick to to make this decision?
Are you asking about the measurement of cochlear nerve?
Or like, the cochlear nerve, yes.
See, it's been mentioned that if the cochlear nerve is visible, even though so you can always go for an implant. Even if it is a thin hypoplastic nerve, you have to give, as Mr. Sir is mentioned now, when he went to Australia, like we do hearing aid trial, they do cochlear implant trial. Like if the cochlear nerve is visible, even a little bit, then you have to go for the implant.
But Pagya, I think you have a more rule here than the radiologist. So the question I'll revert back to you. Because ultimately you people have to give my decision that this case I'll go for brainstem implant or what Sanchita has said, that's trial of cochlear implant. So I'm put a little bit of diatemy here because this muscle is here. Pagya, are you listening?
Yes.
So how do you give that as a one of the senior team member, that sir, please go for this, I have getting this response. So what extra test you will do and how will convince me that we are going for getting some response.
In this case, in such cases where we do see a deficient cochlear nerve, I mean, if it is just a deficient cochlear nerve, we, as Sanchita Ba said, I think we would still go for a cochlear implant. And because from what we have learned and what the experts have been saying, that cochlear implant, the chances of benefit from a cochlear implant is still much higher than an auditory brainstem implant. But in cases where probably it's hard to see if there is any nerve at all, we have to go for measures like the electrical ABR or through promontory stimulation. to see if we can get any response at all if we directly stimulate, electrically stimulate the promontory or the round window. So that's one of the measures that we have to take. But there are chances that it's a very thin nerve or highly deficient nerve. Even with electrical stimulation, we may not still get a response. We also have to depend. We cannot discount the role of behavioral observation. So
Yes.
in case of deficient, even if it's a deficient nerve, as long as some amount of stimulation is going, there will be some perception that we will expect. So even with the use of a hearing aid also, we can observe if there is at least some amount of detection that a child is able to do with a very powerful hearing aid. It may not be useful for any speech perception as such, but at least detection responses if we are able to elicit from a child. So a combination of both electrical stimulation and as well as behavioral observation is what we will rely on. From my point of view, Rosina and Mansi, would you like to add anything to this?
Yeah, I mean, we had a similar case, not where the radiologist did not specify about the presence or absence of the nerve, and we had to rely 100% on the behavioral responses of the child. The child was coming for pre-implant therapy. So the child was using hearing aid for quite some time. So based on his aided responses, we had to go ahead with the cochlear implant surgery. So behavioral responses, I mean, are actually very, very, very important.
Yes, that's very important. What about the picture, Pagya?
Sorry, sir.
What about the video, the picture there?
Picture, it's on and
fine,
off,
sir,
on and
fine.
off, it's coming in. Again, it's gone.
It's coming consistently. I can see clearly.
Oh, it's for you, it's coming consistently. Okay.
It is Mansi network. Okay.
Okay.
So you can appreciate this flap, and you can appreciate the adequate pocket for the internal processor. Can you appreciate?
Internal processor, yeah.
Right.
This is a good adequate flap, and Mukherjee sir, if you can appreciate, I am not using at all diathermy.
Right. Yeah, very correct.
And if you see for the juniors, how ultimately for the closer part,
Yes.
because ultimately sensitively requires this anteriorly tissue, and this is the repair from the floor side. We can do now also. Let's put a detector here. Let's put a detector. This thing is very important, sir. So that because after putting your electrode, you will not allow to for your diathermy. So mobilize everything beforehand. So that you can have a good closer, not a tight closer. Because if you give a tight closer, then there is a chances of necrosis.
Yes.
Yes, sir. A counter voice Ravi. Sir, you can take that mic.
Robbie, give that one.
वो सर के लिए है. Sir, can you see this is and Robbie sir has a speech another third flap from here sometimes when we have also experienced this same thing. It is not adequate. So I think there will be adequate closer, sir, later on. So this is the day. Stay and forceps उसको निकालने के लिए. Mukherjee sir, how is the picture?
No, it's okay. It is okay.
There, thumb forceps.
Clean field.
We are surgeons. We are audiovisual same, sir.
Correct.
So we generally don't put detectors, sir. We go it very loosely. इसको तुम लोग सिल्क देना सिल्क ये ठिलन कट जाता है.
Hello.
Yeah.
Sir, there were a couple of questions from Fukan sir and Mukherjee sir also. I think again it's from the radiology part itself. Fukan sir had asked any measurement in vestibular aqueduct. I think sir was asking about, is there any particular measurement that you make or that you look for in the vestibular aqueduct?
Yeah, Pragya.
Yes.
Yes. Answering that question, in Sinergulu's book, it's written that if the diameter is more than 1.5, then it is considered to be an enlarged vestibular aqueduct. Also, we have to compare it with the diameter of the posterior
semicircular canal. Yes.
Yes.
Posterior semicircular canal. You can compare with that.
Yes.
Mukherjee sir has also asked how to assess cochlear rotation. I think Sanchita discussed with
These
the
two
tangential lines. Right.
Yeah, tangential line from the posterior wall.
Yes. Already discussed.
Yeah, another sigmoid sinus.
Yes, sir. Yes.
Some people say cochlear rotation is an exaggerated thing.
That's what Satish Jain was telling the other day. I asked the same question. I got the answer. It is exaggerated. Manish Grover is doing a lot of work on that cochlear rotation.
So we people are just student of everybody. So we have to follow everything. So deal.
Both are from Jaipur.
Hey, Sarko dena.
Both are from Jaipur.
Yes.
Counter hudok san apni audible hoy nahi. Saline suction. Yes, sab le lo. Saline suction. So I'm going for standard cortical mastoidectomy.
Yes.
So can you appreciate this is a cubiform area? Do you know, Sanchita, what is the cubiform area? So you have mostly in radiology you have covered the different type of cellularity now.
Yes.
So this, what is the cubiform? What is the significance of this cubiform? Suction. So why there is a cubiform? This hole is there. During the process of change of cellularity, these Haversian, these are actually blood vessels. These are Haversian canals that remains. When they've transferred from marrow bone, then a little detector here, maybe anterior police. We can little bit of yes. So is my picture centralized?
Yes, now it is centralized.
Now this is the superior part of the canal, external canal.
Yes.
This is the cubiform area. Pani badao na, pani badao. The posterior superior.
Spinal friendly.
Speed कम करना थोड़ा. Jumping bar is on. दूसरा बार दो. Suction नहीं हो रहा है मेरा, suction नहीं हो रहा है. Please. Bar sense करो. Suction. दूसरा बार दो. Suction, please, ma'am. Suction. नहीं हुआ, suction नहीं हो रहा है. Suction sense करना है, इसको sense करना है. कैसा आवाज आ रहा है? म्यूट कर देना किसी को.
Another question for Sanchita and sir both. So far, how often or how frequently have you come across deviation from a normal facial nerve course? And like for us, sometimes we have seen in very few patients that
Manila.
facial nerve bridges with even small amounts of current, or as we increase the current level. So I just wanted to know when we should be cautious.
I can't hear. Just wait for some
Hello?
time. I can't hear.
Okay, okay, all right.
Filling work is going on now. I can't hear. Just wait for some time.
So it's a good cellular mastoid, as Conchita has told in the radiology part. पानी ना लगा सुनते Conchita तुम बाहर रेडी रखो ना नेक्स्ट बार Consider what is exenteration, what is eradication of mastoid cell? What is exenteration, what is eradication of the mastoid cell? Eradication. So, क्या रखो ना बहुत पानी आ रहा है
If I may, I have a question for counselor since Bisoda is busy with the surgery. Counselor, if you can hear me?
Yes, yes. Yeah, I can hear
Yeah,
you.
sir. Yeah. So good morning.
Morning.
So you all have you all do mastoidectomy for diseased mastoids and also mastoidectomy in cochlear implants. How are the procedures different in both the cases?
Usually, when we do a diseased mastoid, there is already some amount of bone erosion because of the infective process. Even if you're doing it in a cholestotoma or some other forms, mostly we do it for cholestotoma. So there's always some amount of infective process going around, and there will be definitely a lot of bone erosion because of that only you open the mastoid.
This is anthem.
So it is not like it's like going into a virgin territory here as Biswajit is going in now. There's no infection, there's nothing. It's just a normal, absolutely normal mastoid bone with a lot of air cells that is trying to remove and find out the editors. So that way, it's much more easier to do the mastoidectomy part in a cochlear implant than in a diseased mastoid, because you never know where some structure is, I mean, eroded and open. Like yesterday, I did a cholestotoma in a young girl where the dura was exposed, and at one place there was a subdural abscess. The lateral semicircular canal was eroded. The bony part was eroded. The membranous was there was a small opening. The membrane was intact. And so, in those cases, you have to be very, very careful. But when we are doing in a cochlear implant surgery, since it is not a diseased mastoid, we generally, and we read the CT scan and MRIs much more than we do in a cholestotoma. So we go in with a lot of confidence. But when you're doing it in the child, sometimes you are actually scared that you are doing in a very small space, but it is not so. The mastoid size actually does not, with your magnification on the microscope, it does not matter so much.
Okay, sir.
Only thing that we have problems is when you have diploid bones and you have a lot of bleeding from the bones. That is a issue sometimes in a child. And of course, in the cochleostomy, in the posterior tympanotomy part, if your opening is not adequate, then you are of course having some problem. But as you go along, you start realizing how to tackle those issues gradually. Yeah.
Right, sir. Sir, again, a question to you. We are almost heading our 50th surgery, and you also had experience with different companies. So, which would be your personal favorite if you ask for? I'm asking from implant point of view, not an electrode point of view.
Yes.
Which company would you, I mean, as from a surgeon, cochlear implant surgeon's point of view, which company would a surgeon go for?
I get your question. See, most of the time, as they say, beggars cannot be choosers. Most of the time, a majority of the cases were done on EDIT patients, and we were not in a position to choose our implant. We had to take whatever we were given. So we had the experience of using mainly cochlear implants. Then we used implants from Digisonic. I think these are the two companies, the majority we have used. Then we have used in a couple of cases metal implants, but we have no experience with advanced bionics. We have not used a single implant from advanced bionics, so I cannot comment about the two. There are two things. One is the ease of using the implant, the ease of inserting the implant, and the ability to have a proper assessment after the implant is in the electrophysiological test, and lastly the post-operative follow-up. With all these, on all these counts, I think Cochlear scores much more over the other two, because Cochlear, the implants are much more well researched. They are very, you have a lot of choice, different choices. Then the electrophysiological testing that is done on the NRTs that are done, if you have a problem, the backup is very good from the Cochlear team. So I'll be more biased towards Cochlear. Digisonic has got the advantage, especially for a beginner. When we were doing cochlear implants in the initial stages, Digisonic, which is from France, is easier in the sense that you don't have to make a well. The well making actually is one of the more difficult, I will say, part of the cochlear implant surgery, because you have to pull the soft tissue and try to do the drilling in an oblique manner, not in a vertical sort of direction. So Digisonic, you have to just tighten the screws. So, and the electrode is also very sturdy. So in the initial stages, when you're handling a cochlear implant, I don't know about others, what used to happen to me is that you start realizing that you are holding a very costly equipment in your hand, and your hand movement is now going to decide the fate of whether you break it or you use it properly. So that makes you a little nervous in the beginning when you are handling a cochlear. As you can see now, Biswajit has exposed the, he has just opened, he can see that he has opened the mastoid nicely. You can see the bulge of the lateral semicircular canal. He has exposed the adductors, and you can see that he has made just a small opening into the posterior tympanotomy. I think I'll give it to Biswas now.
Sir, this is, sir, I think, can you appreciate, this is a mastodectomy. I am not interested on this part. I'm not that much of interested on this part except the editor's exposure. And you can appreciate the lateral semicircular canal. There's a bridge of bone here, which I'm going to drill gently, because then you can see the short process of incus. And I'm more interested towards the anterior, the posterior canal wall. This is how the thickness is there, the posterior canal wall. So we have thin and towards the tip little bit because of my insertion angulation. And you can appreciate there's a cell. This is called sentinel cell. Some people, this is also called as a cell of Hall cells. And this is one of the landmark, and it is also called perifacial cell. Most Sansita has appreciated in radiology also. So I am not going to spooning all this mastoid cavity. That's all, and I am almost in the thinning the bony wall, and I am going for the posterior tympanotomy. And this, I think, sir, Counselor, this cell will guide me now, sir. This cell is, so look how this, first time we have seen how big cell is here. But before that, most probably I'm going for my most important landmark, the incus. Mukherjee sir, you can appreciate the shadow of the incus. Can you appreciate the shadow of the incus? Can you appreciate the shadow of the incus? I don't know.
I can see incus shadow.
Sir. Can you appreciate the incus shadow?
Yes, very much.
This is the most important landmark.
Yeah.
And I still can do gentle drilling here. I have to appreciate I am always with the side of the bar.
Yeah, yeah, correct.
I am always side of the bar.
So that you don't injure. Yeah.
Gently, without pressure. So I am going exposing the short process of incus.
Yes.
Hello.
This is
Uh,
this is
Yes,
how beautifully
yes.
you can appreciate the incus.
Yeah, yeah.
So this is the beauty of good
Appreciate very clearly.
microscope, good magnification, and now I'll go for the implant bed. So where is my facial?
Yeah, there. Perifacial cell.
There are 3-4 landmark here.
Yeah.
There are 25 landmark for facial nerve. I'll share that thing to you, sir. There are total 25 landmark for whole facial nerve. Facial nerve, how many parts? For
Mansi, I'd like to make a comment here. You wanted to know the difference between drilling in a CI and a mastoid. If you're doing in a
Yes, sir.
mastoid, the drilling part near the incus has to be very careful, because if you hit the
Yes.
drill on the incus, you may cause a sensory neural hearing loss in a hearing ear.
Yes, yes,
But
yes.
here there is already sensory neural hearing loss, so even if you touch the incus, nothing is going to happen really. So that is also another important difference.
Mukherjee sir, how
Dissecting.
good sentinel cell guiding us.
Yeah, it is guiding you. It is guiding you. Don't worry.
Yeah.
I was going to request you to use diamond bar, especially near the incus. I was feeling that way. Because not to disturb that ossicular chain and all. Though
Yeah.
I understand there is already SNHL and all. But to make it intact, keep everything intact.
मार्क्स ठीक से लगाओ ना मेरा मार्क्स ठीक से लगाओ ना मार्क्स का ऊपर टैप लगाओ आई हैव नॉट सीन इसको ड्राई करो ड्राई मॉप से करो ना टैप माय डेशन मार्क्स के ऊपर some sound is coming. Ravi, mute kara na sound ko. I'll create a ridge of bone here. There's a short process of incus. Or you can see there is a communication. Pani dalo, yahan pe pani dalo.
Vishwajit, just a minute. Rosina wants to add something here.
Pani dalo.
I could see a question from Fukan sir that why the 5-year child is selected for the cochlear implant. So yeah, we all know that the best outcome we get it if we implant it early, at least before 2 years for the neuroplasticity. But then this patient came to us when she was already about to be 5 years. It was already late. But then we counseled the parents and they also got motivated for the CI, to go for the CI. And lastly, 5-year is all, like it's late, but it's not very late that the patient will not get any help from the CI. So when we do the, we have the auditory hierarchy. So at least she can go to the identification level. So at the level of the comprehension level, she might not achieve till the higher comprehension level, but at least till identification level, she can get a benefit from the CI. So parents already aware about all this, and we have counseled the parents about all this, and then we continue to go for the CI.
Thank you, Rosina. As you can see now, Vishwajit is thinning the posterior canal wall, and as Dr. Mohan says, you have to make it as thin as the china dish, I mean ceramic. You must be able to see your drill through the very thin posterior canal wall. As Mukherjee had commented about the use of diamond bars, yes, diamond bars are safe, but they also generate a lot of heat. So that is why many people nowadays say that, see, if you are following 3 basic landmarks, there may be 50 or 24 as Vishwajit has said. 3 basic landmarks is number 1, your lateral bulge of the lateral semicircular is number 1. When you see the lateral semicircular canal, you know that that you cannot go below the lateral semicircular canal at that point of time. And your direction of the drilling is always in the direction of the nerve. So where Biswajit is drilling now is away from the nerve only at the lower part where it might come a little nearer. But at this point, the nerve is again moving more medially towards the stylomastoid foramen. So that is why many people say that using the diamond will cause a lot of heat generation. That might again inadvertently, even though it protects against, but when you're drilling under the microscope with accuracy, once the bone is thinned out and the sheath is exposed, you will be knowing.
Thank you. Today they are all new bars and come karo.
Biswada, this question is for you. What parameters on radiology would you use to predict the visibility of the round window before you go for the surgery?
Mostly already Sanchita has covered anyway. There is some measuring, yeah.
I think Sanchita has very nicely shown during the radiology demonstration where you draw 2 lines along the posterior canal wall, and then there's another line along the posterior wall of the mastoid where you see where the approach to the round window, and there is another approach where you draw 1 line along the posterior canal wall and the other line along the basal turn of the cochlea to see whether these 2 lines intersect. If they do not and remain parallel to each other, then you know that you have got a good approach to the round window. But if they happen to intersect, then you know that you are working in a narrow space.
Right, sir.
छोटा सेक्शन देना है कौन सा ठीक है सर अच्छा छोटा ना थोड़ा क्यूरेट देना मेरे को क्यूरेट और छोटा क्यूरेट और इससे छोटा क्यूरेट देना it's not round enough no corda this is corda sir this is corda sir can you appreciate the corda this is corda I should not go anterior to corda now I think this is corda can you appreciate the corda I should not go more anterior to corda now this is my anterior limit
very correct
take a smaller bar because sir the injury to the canal wall is more catastrophic than your I'm not telling I'm not want to say that injury to the facial nerve but you need a very good follow-up and you should not be diamond le lo thoda diamond le lo
yes
पानी and diamond थोड़ा diamond दे दो उसको हाँ सर कोर्स diamond है ठीक है yes sir this is a stabilizer tendon sir this is a stabilizer tendon sir this is a stabilizer tendon sir this is a corda my anterior limit I have reached
posteriorly facial
So I got logged out for a while. Have you already made the implant bed? Okay.
I am extending the posterior tympanotomy
Yes, yes,
because I have already anterior limit, sir.
yes. You can go till the origin of the porta tympani.
Yeah.
Fukan sir is asking what is the size of the burr you're using now?
There's a 1 mm bar now. Some block. At least we needed 2 mm.
Yes.
Smaller coarse diamond. You see, same size. Same size, same size.
Yes, yes.
I can't go bigger than this one now. So some people put betadine in the external auditory canal so that they know if there is an injury in the bony annulus, the betadine
Yes.
will fall over the middle ear.
So what can be the long-term impact if the bony annulus is hurt?
We have to need a good follow-up for that, because there is, if the child has a upper respiratory infection and chances of retraction pocket,
Yeah.
maybe there is a chances of cholestoma, which we can term it as a acquired cholestoma or iatrogenic cholestoma. So I have seen some soft tissue here. I am doubt. So diamond needle, na?
You can take a small curate
Yes,
or
sir.
a right angle pick and try to
Yes.
dissect a
Let's
little
see the
bit
half.
posterior.
I adjust my picture. You adjust, consider you adjust your picture. So this is promontory, sir. No. You adjust. Okay. Then a diamond, coarse diamond. No.
So we can see the chorda anteriorly, we can see the bridge of bone, and we can see the stapedius tendon superiorly.
Yes, yes, very correct.
Posteriorly, you have a small shelf of bone which is
Yes.
obscuring the
View of the seven nerve.
which is obscuring the pyramid. Actually, we can
Yes.
take out that small shelf of bone
Pani
either with a curate or with the drill, and we can go towards the apex of the
Apex of the facial recess.
yes. The posteriorly we can come a little more, but very carefully. And the direction of the drilling is very important at this point of time.
Yes.
Because if you have the sheath opening up at any time, we should know.
Rosina, I think Fukan sir has a question for you. Is the deafness in this case, is it prenatal or postnatal? Infection was there in both periods. Rosina, I think the child had a history of typhoid.
Yes.
Because she
No,
got typhoid at the age of 6 months of age, but then parents are reported that she was not responding to sound even before that.
Right.
So it could be congenital, sir.
sir.
Vishwajit sir, in this at this point of time, if in case somehow the ossicular chain gets disrupted or gets some kind of injury happens,
Doesn't matter.
it won't matter. Would it have any impact at all?
No.
Not at
No
all.
effect, but you required this thing now. If you want to go for this is your third measurement now. Reflex. So that's
Correct.
why you not disrupt the ossicular continuity and stapedius tendon. And neither how you elicit your stapedial reflex.
Stapedial reflex. In order to observe the stapedial reflex, yes, will be important.
But you asked Vanisula, what is
Yeah.
Vanisula?
What am I doing? 10 baje?
Yes, Rosina, can you repeat?
So somebody asked what is Venezuela? It is a second box, same term.
Sorry?
Mother had second. Somebody asked what is Venezuela? It is
इसका
a
छोटा
it is
बार
a
है ना,
second
पानी पानी
box.
रखना
The
चाहिए।
mother had second box
Okay.
at a 5 months
Okay.
old gestation.
Okay. So in the previous, I think 1 or 2 cases, we had tried eliciting the or observing the ESRT, stapedial reflex, but we could not observe. What could be the reason, sir?
Maybe we had did the stapedial reflex when there is a patient is full paralyzed. Full paralytic agents was used. So when you go for to see any nerve reflex, so better to discuss with your anesthesiologist that I'm going for this nerve reflex monitor measure. Then ask them to withdraw the muscle relaxation before starting the the patient will be under sedation, but she will be not, the muscle will be not paralyzed. So you need a that plan. Neither you can't elicit any nerve reflexes.
Okay. Coming back to my previous question on the radiological part, so how often have you come across a deviation or a change, abnormal course of the facial nerve, and when would you ask us to be cautious about it? Like when can we expect it to result into facial nerve stimulation through the electrode? So have you come across deviated course of the facial nerve often?
I'm also thinking. Actually, I am out of mind.
All right, you can finish this. My question was, how often have you come across a deviation in the course of the facial nerve? And when should we be cautious about it having an impact on the child post-operatively? Like when, it may result into a facial nerve stimulation through the electrode or something like that.
Okay, that's basically labyrinthine portion. And you can appreciate in a radiology any aberrant course of the facial nerve. Okay. Generally, it is not over the this middle portion or tympanic portion, because I think tympanic portion causes more during the oval window or stapedidotomy region. I think I can appreciate. Can you tilt the head? Consider इसमें membrane था क्या रानो इंदा में? मेरे पास उल्टा बस रवि तुम ये 0 डिग्री एंडोस्कोप को ये क्या so I am going अभी सेंट्रलाइज है एडिनल बॉल रखो ना around, I think
we can just see a glimpse of the superior border of the round window. Just you can put a piece of F-gel there.
Sorry, I don't think this soft tissue is from facial.
No, it's not from facial. Hey, facial soft tissue, no, facial sheet will come, sheet will bleed if you touch with the drill.
Yeah.
So go with a 1 mm drill and try to go to the apex. Try to stay a little posteriorly and inferiorly.
Funny irrigation. सिस्टर सक्शन नहीं हो रहा है मेरा। हो रहा है, थोड़ा बड़ा सक्शन दो इससे। सक्शन दे। और रोटेट करो ना थोड़ा। Nowadays we always rotate the blade. Don't turn the head without the neck. Bas.
Is that for better visualization or better access?
Can you appreciate now the round in the knees area?
Yes.
I'll do the medial part drilling. Little bit drilling.
Yes.
There is a name call of the medial portion of the bone. Consider there is a name. Mukherjee sir, do you know the name of this part of bone where I am dealing?
Yeah, there's some just told. I forgot the name. Yes.
Soda. I didn't ball there.
Yes.
Joel forms liquid adrenaline. So I think I don't require more posterior bone drilling.
Yeah, it's sufficient.
एडिनल है ना, पूरा कॉन्सेंट्रेट एडिनल है ना, और मेरे को छोटा बढ़ दो ना, और ये हैंडपीस भी चेंज करना पड़ेगा तुमको। कौन सा हैंडपीस दो, कौन सा हैंडपीस? रवि रिकॉर्डिंग ऑफ करके ऑन करो ना। हाँ अभी क्या लगा सकते हैं, नहीं सही है इसको। वो छोटा डायमंड बार्ड है,
लंबा बड़ा देगा।
थोड़ा स्पीड कम करोगे ना बार का। ठीक है, ठीक है। I think I have an angulation because I'll go up now. So I have angulation, good angulation now, sir.
Yes.
Always remember this soft, consider, this soft does not cause exposed facial palsy or exposed part of the facial. When you're dealing the medial portion, be careful. This is less angulation, so that it does not cause. This should be float. Yeah. Okay, sir, come on.
Yes. We are observing.
Yeah. Now it's okay. Something is there in front of the round window.
Yes.
Yeah. What is that?
Saline, saline, saline. Can you appreciate what is the angle of the round window now?
Yes, yes.
We can.
Now, suction. Sir. Yesterday I got a talk presentation regarding the favorability of the round window insertion and cochleostomy insertion. So they have measured some angle. I don't know. You can appreciate here. It is almost front facing this round window. So if the angulation is less than 45 degree, then it is good for round window. Can you see the Christoph Fenestra, sir? Can you appreciate the
Yes,
Christoph
yes. Yes, yes.
Possibly the suction is. We should not open the round window now. Actually, I should drill the superior lip of the round window, then more exposed. Then
Vishwajit, there is a request that you point out the landmarks. You can even see the Jacobson nerve also here. You can even see the Jacobson nerve on the promontory very nicely.
Promontory.
You can see the Jacobson nerve going vertically down on the promontory.
We can see. We can see.
Please centralize.
So which nerve? You can see the nerve now, sir.
Why color is gone?
Color is not gone. I am changing the mode, sir.
Acha, you are changing the mode, right? Okay, okay.
So that way you can appreciate different vessels. Now you see. The mood is there different. Now can you appreciate? It is a promontory bulb.
Yes.
Now I'm going. Oh, yes, go out. Come on. Yeah. Barco. Which one is good? Which one is good? Left into diamond. Speed, come out. Heidi. Speed out, come on, yeah. So there's a special bar for, sir. Can you appreciate the bars here? Just a minute. Can you see this long conical bar?
Yes, yes, yes.
The bar for cochleostomy. This one is gifted by Amitav sir to me.
Okay.
Yeah. Because you need a very good bar because neither it will jerk. Speed come out. Speed come out. Come out. और दूसरा बार. Then I bar her.
So you're planning to go for cochleostomy in this case?
No. I'm going for round window insertion. So I'm now going to dealing the superior leaf of your round window. Can you appreciate round window membrane?
Yes, yes.
Yes, sir.
So I am dealing the round window membrane. I'm going for this. How is the picture there?
Now it's better, sir. Yeah.
Good now.
Yeah, picture is good. Can we get more contrast on it somehow?
You can have a look in the YouTube part.
No, I'll have to check.
Vishwajit, straightway round window insertion or doing cochleostomy in the posterior inferior part? Which one is? Yeah.
I'll go extend that round window approach. Let's see after this exposure, sir.
So how do you make the decision? Like, do you make the decision based on the anatomy, based on the implant design, or any other factor?
Anatomy, basically.
Very good question, Pajja. Definitely, anatomy takes always a dominant role.
Anatomy.
And according to anatomy, you may require the electrode, both actually. Suppose you are going for more modulus hugging electrode, that means you are going for more medial electrode position to inside the cochlea.
Yes.
Right.
That way, I'll show one very important thing. That's why, and also most importantly, intracochlear trauma. Can you appreciate the lower leads of bone inferiorly?
Yes,
Really, that is
that is along the floor actually.
that is another foot. That is a Christa fenestra.
Yeah, Kista fenestra.
Can you appreciate it? So that Christa fenestra will ultimately guide your electrode. It's like a speed breaker in Kaziranga.
So can you just point it again? I think I missed it. Can you just point
Exactly
it?
6 o'clock. The round window is 6 o'clock. Then a pick then.
Okay.
Exactly at the 6 o'clock. Exactly at the 6 o'clock. What's that?
It's slightly out of focus.
Can you see the 6 o'clock?
So can you see the mouse?
Yes, I can see the mouse. Yes, yes.
So this is the Christa fenestra.
Okay.
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 This is the Christa fenestra.
Because
Okay.
the Christa fenestra will guide your electrodes towards your basilar membrane.
Then your electrode will go like this. Okay.
So
And he's taking out the lip a little more.
there is a translocation of your electrode.
Yes.
Pragya,
Yes, sir.
since I have the mouse in my hand, so this is your stapedius standard. This is where the vertical portion of the facial nerve is. The chorda was here. Now it's blurred because of magnification. This is the round window niche, and this is where he has taken away the lip. This is the Jacobson nerve on the promontory. Okay. And this is the structure
Your
here.
cursor is not visible actually to us.
Okay. I thought my cursor was available.
The rest of it is clear. Just I'm not very sure about the Jacobson nerve.
Now I am a direct trajectory tunnel. If I go drilling the lower fenestra, okay?
Kista.
But very careful. So I'm not going to expose now. I'll do round window membrane. It's partially yes, maybe done clear.
The diameter of the drill is 0.8.
Yes, sir. It's not 0.47.
0.47.
Now, if my round windows are partially, can you appreciate the round window area, sir?
Yes, you can appreciate.
So I'll not do more work here. I'll go for the implant bed, then I'll come back. इसमें क्या है तुम्हारा? एक पहले dry दो, उसके बाद मैं वो दूंगा. Give me dry one. So I am putting an Abzel here.
We want a clean area.
So I'll go back to go for an implant bed now. One more. और थोड़ा बढ़ा दे दो इसमें. I have not taken soft tissue. Let's take a soft tissue first.
You have to pack around it.
ये देना, scissor देना. Sir. Okay. Then so I'm taking some soft tissue.
Yes.
Detector. सक्शन कौन सा सक्शन लगा रहा है तुम लोग? रजीना इम्प्लांट रेडी करो. हाँ
Sufficient.
लो ना, ये लो सॉफ्ट टिश्यू. अरे रवि, मेरा वो लैपटॉप खोल देना. लैपटॉप खोल के वो रवीना मैडम का लैपटॉप HDMI में दे दो. हो जाएगा क्या? हो जाएगा.
Sufficient.
Sufficient, sir.
Yeah.
So I'll go for the implant bed, sir, now.
Yes.
डिटेक्टर दो, बड़ा सक्शन दो अभी। तो सलाइन एक एब्जेल भी दो ना मास्टर में। अभी इसको रखो बिगा और ये इसको डिटेक्टर दे दो भाई, दो डिटेक्टर दो, इम्प्लांट टेम्पलेट दो। रोजीना तुम वो ट्रॉली ले लो, एक वो HDMI केबल लगाएगा वो, अभी मत लगा, थोड़ी देर बाद लगा। हाँ खड़ी है, नहीं तुम इधर आओ, तुम इसमें आओ ना, टेम्पलेट देना। ये 45 डिग्री, दिस वाज 45 डिग्री ना, ठीक है ना। मेरे को छोटा बार दो, हैंड पीस दो। सामने कटिंग दे, छोटा कटिंग दे। जाने से वो सब खराब बाल कहाँ गया। स्पीड बढ़ाओ, स्पीड बढ़ाओ। सर काउंसर ठीक है सर, काउंसर कहाँ गया। पूरा। So I am just making the boundary of the template.
So each implant will come with a with their particular template, the implant bed template, right?
Yeah.
This will guide you regarding the shape of the implant bed as well as the depth of the bed. Is that correct, sir?
Yeah.
Is there a separate template to measure the depth of the implant bed, or is this the same? Is it the same?
Yeah. No, for this
Same
implant, this is the template.
This is the template to determine the size of the bed, for example, the shape or the size of the bed.
Yes.
Do you use the same thing to measure the depth of the implant bed?
Yeah. That you want the thickness of the implant bed, no?
Yeah, the thickness. Yes, sir. The thickness of the
Exactly
implant bed.
what I'm doing now, Rajina. I'm just limit the most anterior limit actually, the thumb position bed. Now that madam ने बोला ना वो thickness वाला template वो नहीं और एक दूसरा है। Yeah. So Pooja, you are telling about this now?
Yes.
Okay. Yes, sir. Yeah. So this is the one that we use to measure the depth of the implant bed.
Yeah.
The depth. Okay. And is it the same for all manufacturers, or is it
No. Depends which processor you are going for the implant. Like suppose, show me the other. For profile series, you can appreciate this kind of thumb cochlear, this kind of.
Right. The shape will be different. Correct. So recently, I think we have come across a case where I think now post-operatively, the manufacturing, the audiologist from the manufacturing company had asked us about the distance of the implant bed from the posterior margin of the incision.
Okay.
Is it a good idea?
It is always better to have at least 2 millimeter. 2 millimeter. More than 2 millimeter.
2 millimeter. Okay.
That way you can have a good space for your BT processor.
Correct. So because otherwise, I think there's a high chance of
the BT will not sit here and it will be little bit of lateralized and it will fall down.
Or the coil being, bent. The chances of the coil cable getting damaged is higher. I think if the implant bed is too close to the
Yes.
processor.
Mm.
So we can keep an island of bone, which is called Bill's Island sometimes, particularly in case of a younger children. If there is but I think it is a 4-year class, so we'll get good thickness of bone.
Possibility of dura being exposed is there also sometimes.
Ah,
So is that the reason why you were measuring the parietal bone thickness
Right. Ekdam correct.
in the radiology?
Ekdam correct. You are right.
जोर से जोर से पानी दो इसका. We have another special detector by Kitane sir. Can you give that detector? This is Kitane sir detector. So here the advantage is your flap is not injured. Can you how this detector has protected the flap?
Yes, yes, yes.
Pani sister pani. Your edges should be always smooth.
Smooth,
Either
yeah.
there's a chances of injure the implant. Pani. Template देना वो जो भी है. नहीं वो नहीं तुम सब दे देते हो. Chicken भी दे देते हो, पुलाव भी. Yeah.
Yes.
Yes. I can go a little more.
Inferiorly. Anteriorly, yeah. I do very.
Yeah.
So what are the risks if the implant bed is not?
Pajja is okay. Pajja is
Yes.
okay.
Yeah, it looks fine.
Okay.
So what I wanted to know if it is if the implant bed is a little too big in size or larger than the implant, what can be the risk, sir? If the implant bed that you have drilled, if the size of the bed is bigger than the implant housing, what can be the risk?
It will become loose. It will become loose.
They lose and but there will be stay suicide now.
There will be
Stay suture.
the suture. Okay.
Ultimately, there is a fibrosis, osteogenesis, and ultimately,
Yes.
Okay,
the
so there are
long run, it is
chances
a
of, right, there are chances of biofilm formation also, I guess.
No,
Bio
definitely not. Biofilm
integration.
is different because if you don't maintain all this sterilization and
Okay.
cutting.
Oseo integration will be there, as
Yeah.
we do for Baha. Same thing.
Yes, yes. And Sanchita, the question of biofilms is actually about infections. If this is a very sterile area, you are sealing it off from everything else. So if a bacteria reaches there, there has to be certain biofilm is actually colonization of the bacteria, which
colonization.
forms a sort of
Yes.
shield-like structure which does not allow the antibiotics to penetrate. That is biofilm.
Yes, yes, yes.
So in order for a biofilm to form here, it will require the bacteria to reach that place.
Yeah. Very
It
good.
can happen if you are not maintaining asepsis during your surgery, or there has been some hematoma formation which has led to infection, etc. So strict asepsis is the rule of the need of the hour in fact in cochlear implant surgery.
So post-surgically, is there any chance of infection, like even during the surgery, even if you're maintaining the sterility, post-surgically, is there a chance of
I believe if you are having strict asepsis during the OT procedure, the only reason you can have infection is, as you have asked earlier, if you injure the annulus, or there is some communication during the posterior tympanotomy work
exterior,
between the external auditory canal,
Yes,
then
yes.
only there can be chances of now, because the TM is intact, your annulus is intact, the skin of the posterior external auditory canal is intact. There is no chance of actually anything coming from outside, because you are
Yes.
not, as Mansi had asked, this is not like a cholestotoma or a infected ear surgery. You are working in a sterile environment.
Right.
It's an absolutely sterile environment you are working in.
Okay. Why I ask this question is because I've seen that the manufacturers sometimes they take this into consideration quite a lot regarding where to have the imprints on the implant, uh, the markings on the implant. Earlier it used to be on the inferior surface, but now they've started putting it on the superior surface so that the inferior surface is smooth and conforms to the implant bed completely. And again, like the smoothing out the edges of the implant housing. And so that's why I was thinking, like, is it common for infections to reach there later on?
One day you have asked me now.
Yeah.
If I don't, this bed may not be a cellular, many deeper, but I always make this tunnel little deeper. Okay.
Right.
Because there's a more chances, I think, because this electrode, no, this tunnel, electrode channel. If you,
correct.
I mean, can you appreciate this? My 2 millimeter bar.
Yes.
It's covered, no. That I always do. Don't worry for that.
Why is it very important to make this channel, sir? This tunnel?
Because look, this is a very good soft tissue cover. Okay. Suppose you elected a little bit of.
One thing be sure, you have kept a portion of the bone on the tunnel lingular type.
So that
is again to support the wear.
Electrode dislocation.
Yeah. Yes.
So that there is no migration or change in position of the lead.
Pragya, this is actually in answer to your first part of the query regarding the changing of the implant, which is made more smooth, more sharp at the edges, because once it hugs the bed very nicely, the chances of migration of the implants, because that used to happen in the earlier times. We used to see a lot of papers on
Mukherjee sir, because keeping this lateral portion of the cortical bone, can you see that this is a highway for your electrode?
Yes, very correct.
Ultimately. And I'm making the highway for the mastoid part.
because this child is going to grow bigger and taller, and then
Yes, yes.
implant will also
Our face also will grow naturally.
The most tedious job of making the hole. I'll do one, and rest ये तो पेरिस्टम में डालेगा, हाँ? ठीक है?
It's also it's quite known that the lead part, the electrode lead part, which just comes out of the implant housing, that is the most delicate or vulnerable portion of the implant, which in case of any impact, that is the region where chances of damage to the electrode is highest. So again, putting it in the tunnel and covering it with the tissue kind of protects the lead area, apart from preventing any migration or movement of the lead.
Yes.
So do you always go for tie down, or do you always prefer to do tie down?
I prefer tie down. I prefer tie down in case of a division also. But I have heard some great that there is a long-term micro-migration, all these things happens. And also sometimes a microtoma, suppose a child is playing and there so that way you can help.
Correct.
I have seen Mohan sir, everybody. Mohan sir did one workshop here, and in a division implant also, he is not going for the screw. But that was a different issue for the screw part. But I've seen they always go for tie down. In fact, profile please also generally they does not require tie down. Am I right?
Right. Yes, sir. It does not necessarily require.
But again, many people, at least today also I am going for one side tie down, one side in the bone, other side in the microperistome.
Right.
This should be 90 degrees. Then your implant will sit properly. Okay, consider. This should be 90 degrees exactly. So you can take a smaller bar, then you can make this kind of this thing. Sorry, Mukherjee sir, I'm taking little time.
No, doesn't matter.
Pani. Good thickness, very good thickness.
Yes. Now you'll enter towards this blade. Yeah.
Pauline, if you want pani do. Susar leke आओ. Susar क्या लगा? If you want 30 है. Pani. If you want. और नहीं तो Pauline दे दो सिर्फ. Pauline 30. Pani. Now, Amit ki Susar, all these people use Ichiban. Many people nowadays use Ichiban. I don't know. Ichiban है क्या? हम लोग के पास 30. हाँ. है क्या? Let's try Ichiban 30. निडल देना सुसा आ गया Pauline दे Pauline ठीक है
No, sir, it's from Cochlear. They're using Cochlear medical device.
पानी पता लगा लो
The name is very the name itself is Cochlear, so it's difficult to say Cochlear implant.
दे Ichiban जो भी है Pauline दे हो गया उसमें एक हुक देना कुछ जा रहा है कि नहीं देखते हैं काउंटर कहाँ गया Implant parameter.
Sir, previously asked Rosina and Mansi, I just put this question to you. Fukan sir had previously asked, I think when we were talking about deficient cochlear nerve and the importance of behavioral response, observing behavioral response. So Fukan sir had asked, how will we counsel the parents based on behavioral response? So what has been your experience, Mansi, Rosina? Have you been able to counsel parents or convince them solely based on the behavioral response of the child? Rosina, Mansi, are you there? Hello.
Hello. Counseling for CI, right?
Then
Counseling regarding the presence of a response or the prognosis based on the behavioral response of the child. How has been your experience?
So when we counsel for CI, it's like counseling is
excellent.
All the
Excellent, Sansita.
audiological
Counsel.
test finding.
Excellent,
and,
Sansita.
behavioral audiometry
Single
test
shot.
finding. All that we have to see, and we have to
This
based
is the
on
most
that we
serious
counsel
job.
the parents. Okay,
So
how
we'll
much
go.
the child.
One second, Rosina. Rosina.
Okay. इसको clean करो.
Hello.
Yes. Yes.
Your voice is very low. I'm not able to hear.
Can you hear me?
Yeah, better now.
Can you hear me?
Yes.
Okay.
Yes,
So,
continue.
yeah. So counseling for CI as such, like we have to see for the like not only the behavioral response, we have to see for the other the audiological test finding and how the child is how is the actual hearing through the behavioral or like the audiometry responses, and also the added responses, how the child is doing, how the child is hearing from the hearing aid. So based on that, we can also like, something that how the child will be doing from the implant also. So
correct. I think so. The question is in cases, especially in cases where we don't see any objective responses. In those cases, when we have to counsel solely based on our behavioral observation, just wanted to know how has been your experience. In my experience, this is where pre-implant therapy comes into play. When we involve the parents in the pre-implant therapy process, we not only prepare the child, we also prepare the parents. We orient them to understand when the child is able to hear, to identify when the child has been able to detect a sound or respond to a sound, and when the child did not hear. So that way the parents also get oriented. And so it's not just our opinion that we are giving to the parents that yes, the child is hearing or not hearing. The parents themselves are also oriented, or they are also able to identify when there is a response or not. It is difficult, most definitely it is difficult, but I think that is where the role of pre-implant therapy becomes very, very important. And like you said, Rosina, aided audiometry, that itself is a documentation of the behavioral response itself of the child. And when we present it in the view of the speech spectrum, that makes it much more easier for the parents to understand the visual representation.
Come on. Suction, not suction. Suction.
Thank you. I hope that answers Fukan's question also.
Suction.
I believe, sir, the tie-down suture is done.
Yeah, sir.
Now, one thing I want to know, Bishnujit, do you use electrocochleography during along with the implant? Do they give electrocochleography for know the residual hearing?
No, sir. No, we haven't known that.
No, sir,
no provision for that.
Yeah. Till date.
Okay. Well, I got in the literature, they are telling that they are supplying with that.
But we have seen some literature only. We have not seen till date. Nobody is doing here in India. Because looks are, it is a
So it
very,
is still at a research phase, I think, the use of electrocochleography,
suppose sir,
more especially to know the
Lot
trajectory
of
of
gray
the
areas are there in the electrocochleography itself. Lot of gray areas are there.
correct, sir. And in
Suppose-
practical clinical use, it has not yet been implemented clinically, I believe.
1 hour.
Especially because now we have the provision of
Bera.
NRTs.
Yes.
Yeah, NRTs, which is essentially the same thing. The first
NRT is
piece
of course,
the
yeah.
idea.
Yes.
So
Very correct.
since I think most of the manufacturers are providing the facility to carry out NRTs across electrodes, that itself gives us a very good understanding of
Implantation
yeah, the response
integrity of the electrodes, integrity of the, yeah.
Correct. So integrity of the electrode, and also if the electrode is in the scala tympani, it's able to stimulate the auditory nerve. So all of that information we are getting from the NRTs. I think electrocochleography also is being used to monitor whether the trajectory of the electrode
Yes.
array as it is being inserted.
Ekdam correct. You are right. That is
Right,
the
right.
reason it is supplied with the cochlear implant.
So, sorry to interrupt in between. I think Bisha has opened the round window membrane and you can see the endolink coming out. You can
Yes.
see the endolink coming out. Can you focus,
Not
Bisha?
focused.
Yeah.
Yeah.
You have opened the membrane with the right angle peak, and endolink could be seen coming out actually. Magnification बढ़ाई ले भाग के निकले.
Yeah, boss. মই কোন যাইছে
और
তো
भी lips और मारा.
This is the area of Krishna. You have already opened up that area.
घूम नहीं रहा है. Stop हो गए बाहर से. Yes. So I am in a very low speed, sir.
Yes. Yes. You put steroid solution over there.
Yeah, I'll put, sir. I'll do little bit of
Yes.
Okay,
Yes.
sir.
Correct.
Are you okay?
Yes. We can see the direction of the, yeah. Oh,
So
we
you
can
have
see.
removed the false membrane of the round window?
Yeah. Dena. Oh, hook dena. मैं तो कार में डाल देना.
Yes. Bus. Sufficient.
Can you appreciate the crista? There's a good amount of
Yes.
crista is there.
Yeah, I can see.
Can you appreciate that this amount of bone? Consider.
Yes.
7 up.
Yeah, now it is okay.
Curate.
Curate though. Yes, correct.
नहीं वो क्यों नहीं वो कार्बन ये क्यों रहा भाई ना ब्लीडिंग तो
Microcurate. Yes.
इसको ये साफ करो ना, सबसे बॉल को साफ करो ना, क्योंकि ये टनल को साफ करो ना, इतने साफ कर दिया बड़ा सेक्शन देना. So I'll do little bit of more deal over the because crista, near the crista, there is a cochlear vein. So
Yes.
blindly you can't do two more drilling there.
It will start bleeding otherwise.
Now your whole surgery will be jeopardized then. Because it's the only vein. So better to drill here.
Anteriorly little.
छोटा सेक्शन है वो पहले वाला.
আরেকটু depth যেতে লাগবে. Little more depth.
देना सेक्शन दे. थोड़ा कर सकते हैं. इम्प्लांट खोलो. डेक्सा.
Yes.
Now you see, sir.
I can see now. I can see. It has winded up and actual trajectory direction is there on that side only.
Yeah,
You'll insert on that way. Yeah. You require a little peak to remove this portion, lower portion.
CSF is coming, huh, sir?
Yes, it is coming. It is coming. Yes. Yes.
There is some amount of CSF leak. Are you going to wait for it to slow
sorry?
down, or are you going to insert? Are you going to wait for the CSF leak to slow down, or is it okay?
Patient to high voltage division, हाँ, अलग रखियो पाई भी नहीं. I know, sir, but Daisy, what Daisy? More stable reflex to somehow talk on adha ke desun. Mane relaxation to. Na itian hoy, itian kon de ase homoy. Olop. Itian de adha man de. Itian hoy electrode bhora bisote hobo. It nokore. Straight injection de. No, amma.
Yes.
I think it is adequate.
Correct.
Not this soft tissue only.
These are soft tissue.
The injection, isn't it? Change me though.
So, sir, this was round window or extended round window?
It will be the extended round window.
Extended round window, not round window itself.
Okay.
It is not exactly round window.
Sir, any particular reason to go for extended round window instead of round window?
Because it is a direct trajectory.
Direct trajectory for insertion.
For the scalp
electrode. Yes.
Can you appreciate now?
Yeah, we are appreciating. We are appreciating.
Can appreciate, yes.
Now electrode, crystal drill, little drill, not that much. You want more drilling. Counter out drilling लगाएगा नहीं crystal, then हो जाएगा. Now I think it's adequate. And
Adequate.
It's still also slim state.
Right, sir. That's what you. So slim straight
It's slim state electrode. It does not require more. Coat. Gel form de do. Patient aise, patient aise. অকমান লাগে আধা আধা তাৰপিছত আকৌ আহিব লাগে মানে মাছৰ ইলেকশ্যন উইথড্ৰ কৰিব লাগে এতিয়া আহিব নিদি ইলেকট্ৰনটো ভৰাই লওঁ বেজি बस
Yes.
अभी इसको the implant globe change
Yeah. Glove change.
So would your approach be different for a perimodular electrode?
आप क्या
Your approach be different for a perimodular electrode?
no same
You'll still go for an extended round window.
Actually, what has happened,
ultimately
initially
the
the people were not confident about drilling out the lip of the round window. See, initial cases when we did, most of our cases were a cochleostomy. People were doing a lot of cochleostomy in the earlier times. Then they started realizing probably our electrodes were actually in the scala vestibula. We are not sure. Maybe the electrodes went through the scala vestibula, maybe entered the scala media also. We were not sure what was happening. But now, with more understanding of the anatomy, we started going for more of round window insertions. Now, when we started doing round windows, the more understanding of the round window led to drilling out of the anterior lip of the round window, the superior lip. And when we understand that, we know that that trajectory, the direction, because see, in you will know the cochlea is not in the real vertical plane or a real horizontal plane, it's in the oblique plane. So
Oblique
that
plane,
sort of a mental imagery you have to have in your mind when you actually put the electrode inside. So if you have the other electrodes where you have a particular direction to the tip, then also if you have an extended round window, since you have the opening very wide in front of you, you know in which direction the electrode is moving, because you want it to be as near the modulus as possible.
As possible, correct.
This is for I'm making a pocket for ground electrode, before placement. The good amount of pocket towards the zygoma, sir.
Subtemporal plane.
Towards the zygoma. This much is enough, no?
Yeah.
Okay, आ जाओ. Yes, I do. We absorb do, adenal absorb do. चला गया. Canal में भी दे दो. Canal में भी दे दो. ये असले सा यहाँ पर गए.
Oh.
हो गया implant. Ready, come. Recording.
So now the implant has been opened. The surgeon assistant and the nursing staff, everybody has changed the gloves.
Gloves.
Yes, the gloves.
For double protection. Double protection.
Yes, for sterility.
Correct.
And so we are back to Biswajit for describing. And this is, Sambhuda. This transmission is from the Biswa Broadcasting Corporation.
আৰু ভিতৰত যাব দেই বিশ্ব
So Fukan sir is asking if all electrodes all implants have a ground electrode and its role. So yes, sir, every implant
is having ground electrode.
They have a ground electrode because that is important to complete the channel. For the current, whatever current is being sent to the internal intracochlear electrodes, that needs to be dissipated through the ground electrode. Now, most of the manufacturers, they will have a single ground electrode in the implant body, in the receiver stimulator region. Some manufacturers, I know that Cochlear, especially, they have an additional ground electrode. For which sir made the implant, sir made a pocket just now under the temporalis muscle. So Cochlear has an additional ground electrode. They have 2 ground electrodes. So that helps. One, the current dissipation is much more efficient. So there is no residual current left in the left intracochlear. And secondly, that also gives much clearer NRTs. Because we have
neural response telemetry.
Yes, we have 2 reference points. So the software is able to recognize the neural responses much better.
Yeah. So why not other companies are coming with 2 ground electrodes? They would like to copy the Cochlear also, probably.
Yes, I think maybe copyright issues, or maybe they don't think the investment is
worthwhile.
Maybe. So it's true. So we do have, like, at least we have had experience with 2 manufacturers so far.
Right.
3 manufacturers. Digisonic unfortunately does not give us the facility for NRT measurement or neural response measurement at all. We can only check impedances.
Is it cheaper? Digisonic is cheaper or what? It is cheaper.
So, yeah, I mean, as far as we know, yes, it is slightly cheaper. The price is slightly cheaper, the base model. They have only 1 model available in India right now, and that is more affordable. We have only had 2 edit. And from our experience with medal, we have done only 2 cases, I think, 2 or 3 cases. We have done only 2 or 3 cases of medal. And even out of that, in one of the cases, we could not get any neural responses, although the surgery went smoothly and there was no anatomical issues also. So, and when we check the literature, also we have found that Cochlear's neural response, the algorithm is much more robust compared to others. So I think having an extra ground electrode adds to that benefit.
What happened to that case where you didn't get the NRT and all during surgery?
We could get responses post-operatively after making some changes to the making changes in the audiological parameters. Yes, sir, advanced activities, and the child has been responding.
Child is responding.
Yes.
That is a good thing. That is the idea behind, of course.
Right. It's the additional sort of we get a confidence that during surgery itself that the procedure has.
Section block. नहीं नहीं sure.
Pukan sir, you have asked about cochlear model introduction in 2 terms. I didn't get your question, sir. Pukan sir. Cochlear model introduction in the sense.
In full terms. No, how much? That means what sir was asking probably how much the implant is inserted inside the cochlea. It is full turn or 2.5 turns, or that's
No,
what
sir.
sir is asking probably.
Okay. So I think again it varies, depends on the electrode array. It also varies across manufacturers. Some manufacturers, they believe in deeper insertion.
Yes.
And they believe that gives better perception of low frequencies and better music perception.
Yes,
Whereas
yes.
several other manufacturers, they say that towards the apical region of the cochlea, the density of the spiral ganglion nerves is much decreases.
Yeah.
So effectively, it does not add to a lot of perception, even if we try to stimulate in that region.
Correct.
So in most of the cases, the insertion depth is limited to the
1.5.
Yeah, one and a half turn, one turn,
Yeah.
1.5.
Yes.
And again, with perimodular electrode, because they are closer to the modulus. So even shorter electrode lengths are able to traverse a longer distance.
Longer distance. Yes, yeah, I agree. I agree.
What about the nucleus model?
In nucleus model also, I'll just have to verify the effective length of this particular implant. Like the intracochlear electrode length is about 15 millimeters, if I'm not wrong. Yes, this is 15 millimeters. So it covers 15 millimeters inside the cochlea.
There's a mark on the electrode, na?
Pragya?
There's a mark
Yes.
on the electrode, how much to be inserted and all. Already there is a mark.
Yes, yes. There is a mark which guides the surgeon to what
extent you have to
distance
go.
they should insert the electrode.
First 6 millimeter is important. First 6 millimeter. If you can cross the first 6 millimeter, then rest things will follow.
Yeah, Pragya, Rosina wants to say something.
Yes, yes, Rosina.
Active length is 20 mm.
Oh, I'm so sorry. This is slim straight electrode. So active
Yes,
length is
yes.
20 millimeters. Okay, okay.
20 mm.
Correct,
Yes, sir.
correct. 20 millimeters.
20
Because again,
mm.
it's a slim electrode. It's a slim electrode and a lateral electrode. So the length of the electrode has to be longer in order to cover the most effective region of the cochlea. So I think it's
bigger area of the spiral ganglion
No,
cells.
Pragya, I want to
Yes,
ask
sir.
you about what is the concept actually? Many people varies. Some people say it is 1.5 turn is sufficient. Some people say that 2.5 is. Actually, they market like this their propaganda. Actually, what is the fact? Actually,
Actually, it's hard to say because the studies that have been done also have had the results have not been consistent.
yes.
There have been studies where deeper insertion has resulted, especially in better suprasegmental, like rhythm, perception, and the what we call as the suprasegmental features, rhythm, stress, intonation, those things, because those cues are supposed to be provided by lower frequencies. Yes. However, there are a lot of studies which contraindicate that also. There are a lot of studies which show no significant benefit with when the insertion depth is greater than 460 degrees inside the cochlea. About 460 degrees to 520 degrees.
360 degrees is one circle, so more than that. That's all.
Yes, yes. I think cochlear usually they believe in about 460 degrees of cochlear coverage. I think MEDAL usually they propagate a deeper insertion. They propagate full cochlear coverage.
There is Austrian one,
And
no?
the studies have been very inconsistent. So
Medal is Austrian, no?
Yes, sir.
Full introduction.
Full introduction.
Actually, people use their company, they will say that my thing is the best.
Yeah,
They
that
do
is
and
the
half
thing.
turn. I don't know actually. Thank you, Pooja, for the information you have given.
What also happens is that most of the studies, when they carry out in one center, like most of the centers usually use one particular type of one particular manufacturer more commonly. So their patient base will also have one particular manufacturer's device more commonly, and hence the results also get biased.
Yes, yes.
By that.
I have asked you about the years because you have taken the borderline 5 years for the ADP scheme or like that, because your needle plasticity will be far less in 5 years. And still, I think you have to do that. Is at least something may come better than nothing.
Yes, sir. Exactly. That's the philosophy.
That is the formula, I think, no?
Right. And Rosina will be able to tell better. I think the parents have been counseled about the outcomes in this case.
Yes, yes.
Rosina?
They have to be counseled, yes.
They
Because
have to be counseled.
they will
Their
not get
expectation may be
they will not get a full expected thing.
different.
Because the people are now or they Google and this. Therefore, I think South Korea today ban Google. Today I have seen in paper. They ban Google, stop Google, and the other things. Some things are like South Africa.
Okay.
Not in India.
India will never ban. There's marketing like this.
So, you have tied down the implant already?
We have seen. We have seen.
Yes. You tell.
Tied down.
Or more. There, cut short, and down.
Pragya,
Yes, sir.
I want to ask another question. Suppose a child is 3 years old or 4 years.
Yes.
He is like a not hearing type. How will you evaluate with Bera for some if autistic may be acquired also, no?
It may be acquired, sir. So that information will have to depend on the history that we take from parents, unfortunately, because from any of the tests that we do, we won't be able to get to know the duration of deafness. And I think for a 4-year-old child or 3-year-old child, we can do a behavioral assessment also, but it's always best to back it up with an objective test like PERA.
Yes. One thing, Pragya, I want to know what you do in case of auditory neuropathy, where there is a ASSR you do, and then after that you find that there is a defect in the P40 wave and all these things. Then what you do exactly?
In case of auditory neuropathy, I think this is
You
one.
cannot do nothing.
Right. So auditory neuropathy has been one case where I think everybody has suggested a little bit of a wait and watch policy. Yes, sir. Yes, sir.
This is a
ball.
This is a ground electrode now.
Okay.
Yes. So that's the extracochlear second ground electrode.
So wait and watch. That is the word, sir, madam.
Sir, in case of auditory neuropathy, it's better to give some time to the child, because there have been a lot of cases where even with some amount of neuropathy, children have been able to develop some amount of speech and language, verbal language. They have, and again, in these children also at a later stage, they have, been recommended a cochlear implant or sometimes hearing aid also. Because in auditory neuropathy in the earlier years especially, there is a lot of fluctuation in the hearing loss that we see. So a lot of these children in the initial years, they do develop some amount of language and maybe later on require an additional assistive device. But then there are certain cases where maybe requirement of assistive device is seen earlier. So at least till 1.5 years of age, we have to observe these children to see how they are progressing, and we have to keep monitoring them closely. So as soon as we see that the language development is not going or not progressing at the same rate, or it has regressed, it has stopped, we have to then explore the options of both hearing aid and cochlear implant, because in literature benefits have been seen equally with hearing aid also and cochlear implant also. So there is a population who benefit with hearing aids, and there are people who have benefited with cochlear implant. But again, in these cases,
definitely cochlear nerve should be integrated, should be there. Otherwise, aperture, everything you will see by CT scan. Then only you decide, isn't it?
Correct, sir. True. MRI becomes even more important in these cases, the radiological evaluation. So, Dipen, sir, you have inserted the ground electrode. You have placed the ground electrode already.
Now main electrode will be inserted.
So fortunately, we haven't had to experience or explant any of our cases till now. But there are reports where during explantation, if at all there is a requirement of explantation, this ground electrode that the surgeon showed us, the round shape of the ground electrode.
Yeah.
Sometimes because of osseointegration, that becomes very hard to extract, especially in the later years. So nowadays, the Cochlear has changed the shape of the ground electrode, this extracochlear ground electrode also. It has, instead of this ball shape, they have made it into a pin, like a needle shape. Okay. So it is easier to extract. I mean, if at all it is required in the future.
Claw for introduction of the electrode.
There is a flanks, sir. Can you appreciate the flanks? I have to come down to low.
It's not centralized, sir. It's not in view.
Actually, it always should be done in a lower magnification.
It's not in focus, sir. Can we get a focus view?
Yeah.
So you
Yes,
didn't get a full screen also, no? Therefore, we cannot detect actually. I cannot view the full screen. Mukherjee, have you got full screen?
No.
No, therefore.
No, you can do the speaker view in your laptop.
No.
Achha.
What view?
Speaker view.
Therefore, you cannot see.
I got it. I am seeing full screen.
You are
Where?
seeing
By where?
view, sir.
Hey,
Huh?
chatter upor mari dia teta guchi jabo chat.
Yes,
Then it will be full screen. Chat tolor phale chat likha ase na.
Janu.
Etu mari dile tumi pura full screen paba. Moi palu dekho. Moi tomak dekha pai asu.
Olaf dangor pai aru full screen nohoy.
Hey, Olaf dangor pai eche.
Etu full screen nohoy.
আমি সার্জারি দেখা নাই দেখুন ইনসারশন টু চাব লাগছিল আৰু এখন নাই
এটা দেখিছা ইমপ্লান্ট
স্পিকাৰ ভিউ কৰে দিয়া
এতিয়া পাইছো
and introducing sir
yes we are seeing we can see now we are seeing yeah, very correct there is a mark there I can see
the bigger skin there.
Yeah, there is a mark.
Yes, sir.
There is a mark on the electrode.
Full skin, full insertion, sir.
Yes, I have seen. It is up to the mark. Yes. It is there. You can see.
Soft tissue.
Yes.
So the mark means viscera is inserted fully. There's a full insertion.
Fully. Fully inserted.
Then good.
There is the mark on the electrode itself. Implant.
Here in this electrode, there are two white markers.
Achha.
One at 20 mm and one at 25 mm.
Achha.
Can you appreciate the two marks here?
Actually, that is true. You are right. Because past 6 millimeter, 5 millimeter, there will be one turn. So you are right. Because that turn is important.
Can you see two marks here?
Yes.
We have not seen. Oh yeah.
Yeah, we are seeing.
Very small. Yes. Now.
Yeah.
Skin is not there. Very small skin.
Focus apni YouTube to lagai lokson click kori diok jodi nabo share.
Yeah. Ako YouTube na jao tia.
Na YouTube to click kori dekhabo apni.
Na use gajo po na. Use.
Moi dekha pachu hoy ja.
Na tu full skin po na. Tumi ne
full skin po na.
Full skin also you have not got.
একদম উপৰত দেখা পাইছো একদম উপৰত এতিয়া তো উপৰতে আছে
ওপৰটো আমি পাইছো but this is not full skin
না I enjoyed hey Bishwajit I'm grateful. I অলপ এনার্জিটো আৰু স্টেপিকাস রিফ্লেক্সটো দেখাই দিয়া বাস হৈ যাব।
Something is there. Oh.
Huh?
So you have inserted the till the first marker is at the round window. Is that right, sir? Is it, sir? Okay.
You have to put soft tissue around the electrode to avoid leakage, perilymph leakage.
कहाँ दिया? हाँ लाइट लगे होइसे लाइट लगे देखिए तुम मान ओए will you go for ESRT? ओए रोजिना will you go for ESRT? लाइट ESRT please join एक मिनट
এই মুখার্জি
हाँ
কি শার্ট পিনার শার্ট পিনিলো না
পিন্ধি আছো
কি করে থাকে
रोजिना आ जाओ रोजिना आ जाओ टान लेके आ जाओ क्या करेगा ना देखा ना बाबा ना
Sir, is there any consideration while packing, while putting the packing material in which position? Have any?
yes, if you go for your basically there should not be kinking or disalignment of your electrode. And then for your profile 62, for the perimodular position, I think it should be the you should place the electrode in a posterior tympani part inferiorly. बेटा आ जाओ तुमको मालूम है ये ऐसा सेट करना इसको पुट करो आ जाओ
So recently there has been a paper where they have checked the position of the packing material and how it affects the proximity of the electrode array to the modulus.
Okay.
And especially in the slimmer electrodes. They found that
you're going for ESRT. You're going for ESRT.
I think they found that putting the packing material in the superior area.
Sister, मेरे को थंब फोर्स से बोल देना इलेक्ट्रोड को पोजीशन कर लेते हैं और ये दो क्लॉडो So I am housing the electrode.
Okay.
So it will house in the editors.
Okay.
And this way. रुको कुछ नहीं करने का है अभी तुम लोग लगाओ हाँ लगा है हाँ अभी देखो एक मिनट Can you appreciate the stability tendon, sir? This is the tendon.
Yes, we can. Is the stimulus being presented?
Stimulate करो नहीं तो कार्व निकल रहा
Has any changes been made in the anesthesia in the sedation?
Yeah, patient is already live.
Pragya, can you appreciate the stapedius tendon?
No.
I can see it, sir. Yes.
Yeah, it is just
Yes.
above the, so this is the one. Just
Yes,
above
yes,
the
yes.
above the soft tissue.
Hello.
Okay.
You are doing impedance now. Okay, okay. Kar lo. Aram se kar lo. Good.
I think by default, automatically after connecting the processor,
You can
impedances
say
are
the
measured
original laptop na. You can say the original laptop na for a moment. You can original laptop. Switch kar do.
Oh,
Can you appreciate the screen?
Can you see the screen?
Yes.
Yeah.
Explain karo na Rosina.
I can see the screen, but there are two open circuits here.
Yeah. At the 5th and 4th electrode, the impedance is too high. So it's coming open circuit. I'll just try to measure again, once again.
Okay.
क्या है report क्या?
There's open circuit on the
5th and 4th.
Why?
Why you open circuit, ma'am?
Impedance is too high at the 5th and the 4th.
Yes.
It's coming open circuit.
Usually we see open circuit in the basal most electrode
Basal.
if there are air bubbles or some amount of blood or something. But this is not at the basal most electrode. This is slightly more inner. So
Base is here only.
could be an injury to the electrode, maybe, sir.
No injury as such.
Did you have any obstruction while inserting the electrode?
No. Apical में क्या मिल रहा है तुमको?
Apical में सर ठीक है,
Apical is fine and the basal most electrodes are also fine.
4th and 5th.
4th and 5th.
Yeah. Near to the vessel, not exactly at the vessel.
But as such, there is no. Can you maneuver the electrode? Little bit.
So you can try maybe. So,
Sheet this
so
close
it's
wide.
for the slim electrode, it's not. I think it is not really recommended to move the electrode.
Yeah. तो क्या करो?
So it's just 2 electrodes. I think we can manage. Just 2
It's okay.
electrodes.
We can
leave
see
it.
postal
That is
also.
better, but basal and
Yeah.
apical is okay now.
Yeah.
Okay. ठीक है,
Basal
चलो.
and apical.
ठीक है.
So
We
then
can
next
see
go
the
for
postal
ESRT.
also.
Was there any resistance during insertion, sir?
No, very smooth insertion now.
Bisho, can you put little more soft tissue around the electrode?
No, I'm looking for the stability tendon, sir. Now what you are doing now?
We measure the ESRT.
तुम्हारा काम हो गया क्या? वो impedance देख लिया और NRT कर लिया?
NRT नहीं किया, करो NRT.
NRT करो, खत्म करो. नहीं वो आ रहा है क्या पेशेंट? पेशेंट आ रहा है, वो ESRT कर लो, रवीना.
I think let's try the ESRT first and then NRT.
Can do NRT.
Sir, I'm stimulating. I'll
Says-
just stimulate.
If you can focus on focus back on the stapedius tendon.
संचिता बोलो ना कुछ पेशेंट को. कहाँ से बोलोगे तुम?
No, it's stimulating through the tone only from the software. Yeah, I'm stimulating from the software only.
Okay, करो.
The software will give the stimulating tone. So can you show us the stapedius tendon now, the focus?
Okay, I'll present again. Stimulate. Can you just see the any movement, please?
और उसको सेंस करो. तुम वो मॉनिटर सेंस करो.
Yes.
Okay, now. Okay, I'm stimulating.
Can you
We can
appreciate?
see it, sir. We can see it. Yes.
Can you appreciate the movement?
I second. I
Yes,
missed
yes.
it. I missed it.
एक दफे फिर से दिखाओ ना.
I'll stimulate again.
Hey, Sanchita.
Very nice. We can see it, sir.
Let me see again. Let me see once more.
सर वो इमेज डैमेज हो जाएगा.
एक बार.
Okay, okay.
Yes.
Uh,
Thank you.
See, sir.
Yeah,
yes,
I don't
yes.
know. So you can.
I could see twice.
Okay. Should we start the
Impedance.
NRT?
Yes. I think you can start the NRT.
Now you are going for the NRT.
I think so. We should wait. I think we should wait for the child to be asleep again because the NRT levels will be very high.
Yeah.
If the child is not completely sedated, it may be very painful.
Not today. Okay. Please go for sedation.
Okay.
Now wait for. I will close little bit. Sanchita, आ जाओ. Susha Bhikil दो. Monokill. Monokill. चलो. एक मिनट इसको बंद कर लेते हैं. Monokill.
So NRTs when being measured inside the OT, they start at a higher current level. So we should always be sure that the child is completely sedated because it may be very painful.
Why it is painful, Bhaga? And
Because they stimulate at a higher current level and it's stimulating the nerve directly.
It's like shock type.
So, yeah, it's like a
Kind of a shock.
kind of like a shock.
You make a jerk, like.
Correct, sir.
Counselor.
Okay, thank you.
Oh, counselor, mostly we have missed the ESRT part. Very good confection.
Congratulations, sir, Rosina, everyone. First time we could see SRT.
I think we tried once now in the metal
We
implant.
tried twice before, but we could not see.
Yeah.
Yes. The first time we could observe very clearly.
Because of thank you, anesthesia.
Yes.
Actually, stapedial reflex comes because muscle relaxation is totally withdrawn, I think, no?
Yeah, exactly, sir.
Yes, sir.
Moreover, in child, relaxant is not much used, I think.
I use, sir. We
Because
use,
sevoflurane or this thing will sufficient for the anesthesia. Your Ravi Malingam flap is where? Third flap? Ravi sir's flap.
Ravi sir's flap.
Ravi sir's flap.
Actually, Marcella, because of this problem of relaxants, when we had the neuro monitor also, when we did our first translab acoustic neuroma surgery in Pratiksha, we had the they bought the nerve monitor, but we could not use it. When we used it, we could not get the response because the relaxation was not sufficient.
It was too relaxed, sir.
The
muscle was paralyzed, sir.
Because the patient was.
Have you told anesthetist previously?
Actually,
important.
Discussed with the anesthetist, but
somehow
the patient was on a deeper plane.
Deeper plane.
And muscle relaxation. So in spite of having a nerve monitor, we could not use it.
Yes. Nerve monitor.
Bleeding was
You have got nerve monitor there? Huh?
Demo, sir.
Oh, demo.
It should not be done because there is no monopoly of Koro.
Big hospitals have got an advantage. No, they think that they're going to buy it, so they come.
At least your 49 cochlear implant is really successful, and we can also Mukherjee and myself also take a part. I don't know how many.
We are witnessing it.
Witnessing it. No, by witnessing visual impact mean if you give a lecture also it is not to. Now I have seen the implants are very fine. No? Cochlear implant, much atraumatic. I think Manish Gruber will give a lecture in another tone because previously he used to give lecture on cochlear implant. He used to tell there may many hair cells by putting the cochlear implant. We do not know how much success and how much thing we get. I think with the recent addition of these CIs, very fine CIs, with the lateral attachment also, I think that thing is 30% or 40% correct. I don't know, my thinking is like that. What do you think, Mukherjee?
Yeah, very correct. That is right.
There's a lot
Because it is
of a lot of stress being put on structural preservation during cochlear implantation also nowadays, in terms of electrode design, implant design, surgical
that is
techniques, everything.
everything has improved now.
Improved now.
Yes, sir. There's a lot
Therefore,
of focus on the structural preservation.
yes. Because today I have seen the implant very fine, very good and very automatic. Very automatic and
I want to learn one thing. The number of the electrodes. Electrode number of the channels. Does it matter a lot? Because the more number of channels will cover more areas of the basilar membrane, etc.
It's not about the area of coverage in the basilar membrane. There are electrodes which are very long but have fewer electrode contacts, like in metal. So the separation between each electrode contact is higher. So what happens is, yes, the number of channels, it definitely matters. If we have
the channel will matter.
Yes, sir. The higher channels, we will have a better resolution of frequency
Better resolution of the hearing and all.
Correct. But at the same time, the separation between the electrode contacts also make a very important, also plays a very important role, because if the separation is too less, then there is channel interaction. So we are stimulating one electrode, but it will lead to stimulation of the nearby electrodes also. So the implant manufacturers need to generally find a balance between both the number of electrodes that they want to have and the separation between the electrode contacts. So there has to be a balance between the two. Having more number of electrode contacts also is helpful in cases like, for instance, in today's case itself, suppose the two electrodes where there are open circuit, in case the impedances don't resolve, we may have to deactivate those electrodes. But even after that, we will still have 20 electrode contacts still intact inside the cochlea. So the frequency resolution will not be affected that much. But if the number of contacts available itself is very less, then the impact is higher. So the studies so far say that we need at least 8 intracochlear electrodes for considerable speech perception. If there are lesser than 8 electrodes, then we cannot expect benefit in terms of speech perception.
Ukon sir, can you appreciate the closer?
Yes,
you're so nicely closed.
Your BKR actually is 3-flap technique.
3-flap technique.
Because there is no tension in the flap.
Yes.
One thing I want to learn from Progga again. We know physiologically the basilar membrane has got tonotopic effect, particular area, response to particular frequency and all. Now, since you are inserting a electrode, which will act like that, but then how it will signify each frequency in the ear itself, in the electrode, and it will be appreciated by the patient.
So that's what happens. So if the electrodes are also designed in a tonotopic way, but only thing is the what we call the tuning cost.
We are using only the
will be much broader.
We are not using cotton ball now today. No.
I was going through YouTube yesterday. They are telling about the importance of the tonotopicity of the ear, the basilar membrane.
Yes.
The tension of the basilar membrane in the more in the base because of the size of the osseous spiral lamina and all. So the thing is that if that since we are using the electrode which will act like that, whether the tonotonicity will be maintained or not, that's the point.
So what happens is in the electrode, it's designed so that higher frequencies are delivered by the basal electrodes and lower frequencies are delivered by the apical electrodes. So that's how they try to preserve the tonotopicity. so that the corresponding neural fibers are getting, the tonotopic representation of the frequencies. But like I said, the tuning curves will be much broader in case of a cochlear implant compared to natural hearing. And also, like we know, even in our cochlear normal hearing also, lower frequencies in terms of, in case of lower frequencies, we also depend on the rate of stimulation or the phase locking.
Rate of stimulation, right.
Right, phase locking for to understand the frequency, to perceive frequency. But for higher frequencies, it's mainly the place of stimulation. So again, implant manufacturers also try to find a balance between the two. So some of the implant manufacturers like Advanced Bionics and also to an extent Medal, they try to incorporate both the rate of stimulation as well as the tonotopic
amplitude, intensity of the stimulation.
Yes, the electrode selection based on the topicity for frequency representation.
Hey, Pragya, you don't tell much to Mukherjee. He will again lead, he will ask in the next session. Therefore, don't tell much detail.
And it is better to learn, yeah. You can learn always.
I appreciate your learning,
and she
but
is really good.
You have to
Pragya
praise
is really
Dr.
good.
Biswajit Dogoi also. See how nicely close he is. Biswa, what is the suicide you have used? PDS, no?
No, monokill 30, sir. This suicide.
Oh, monokill 30.
Yeah.
Okay. They're non-absorbable, that means.
It's absorbable monofilament.
Oh,
so
absorbable monofilament.
So it stays longer days, mostly 90 days. So
no, that is like PDS.
It's a monofilament, that's why infection is less. So
no, PDS also monofilament. PDS is monofilament.
I am grateful. Vishwa, I am grateful.
Thank you, sir. Thank you, sir.
You have chosen so nicely everything. I am really grateful. Right from Fiesta and Fiesta and everything.
We are planning for the 50th CI actually. This is a kind of a trial version actually.
No. I am really happy. Really happy.
Mukherjee has closed his chamber, but he will not close his chamber. He will start.
So if you see that the suturing now, be careful regarding the electrode position, intermastoid, and also the implant, because if you can perforate the implant now, then it will give this circuit actually. So you need
I'll take leave now. I'll take
Mukherjee, you go to chamber.
Thank you,
Mukherjee sir.
Thank you.
Thank you, Mukherjee.
You can start in a day. You can start in a day. Relax now. Relax now. You can start in a day. So we have started an NRT. Let's see. इलेक्ट्रोड नहीं है बोल रहा है क्या?
पेशेंट सिडेटेड है क्या बोल रहे हैं कंफर्म करने के लिए.
ठीक है आ रहा है. बाकी में इम्पीडेंस ठीक है ना?
अपाइकल में आ गया है
सर. इसलिए ब्लड क्लॉट है कुछ वहाँ पे कुछ है. मैं भी Pagya, have you seen this NRT monitor?
Yes, we can see. We did not get we got NRT in. We got NRT in the basal and the apical also, I guess.
Good. Thank you, Rosina.
It's still continuing.
Fukan sir. Have you seen the NRT?
I have seen the graph, but you interpret according to electrical stimulation.
Rosina, was NRT present in the first electrode? I can't see it anymore. It was initially showing a NRT threshold.
First electrode, we haven't checked. We checked the apical post.
Already.
22
It's measured
is checked.
already. Electrode 1 is measured already, but I think,
Oh, it's measured.
yeah, threshold
Okay.
could not be determined.
I missed it. I missed it. Sorry.
Sir, are you closing the suture? Is sir closing or is he waiting? Waiting. Oh, closing. Okay. So sometimes when you're closing also, because of artifact also, it may be difficult for the software to determine the ECAP. So Rosina, you can tell them when the basal electrodes are being measured, and maybe they can just wait for some time.
Yeah. Yeah, it's going on. It's going on. It got stuck.
No, it's optimizing the electrode. It's conditioning the electrode for NRT. So sometimes if the software detects that the current is not getting passed through a particular electrode, it sends a high current through those electrodes to kind of condition or break free from any barrier like air bubble or any blood around the electrode. So that's what the software is doing right now.
Optimize failed. Unable to decrease gain.
Okay. Go ahead. I think it will measure the rest. So I think there is some amount of blood or something that has gone into the
Yeah, the basal.
Yes,
that's why the impedance is also high and the NRTs are also not.
NRT also, yeah.
In
at the
fact,
basal.
Dr. Biswas was also ringing me up and telling me that they had similar experience, but when you do it next time, it should go off.
Yes, yes.
And it was probably blood or something because he was drilling quite a bit on the lip area.
Yeah.
So one drop of blood is sufficient to cause that muscle.
Also, in one of the case, I think in Manjit's case, like there was an open circle in one electrode, and when they were switch on, it came down. It was fine. So,
was it on the first electrode itself?
I cannot remember exactly, but in one electrode, it was open circuit. Exactly, I don't remember.
Otherwise in the basal electrodes, the NRT thresholds are quite low, which is a good thing. It is a good sign.
The time. Hey, Thora, one. The alternative is out of compliance.
So will you be doing this here?
It was checking the, no, I think third one. Now it's checking the second.
Third and fourth, we did not get an NRT.
No.
CM करेंगे क्या? X-ray करेंगे?
Yes, 4 and 5. Vessel.
Sir, is there any risk as such, if there is blood or anything that goes into the cochlear lumen,
Device fell. So the problem is in the vessel electrodes. Now it lifted. It didn't come. It didn't come. Now it did not come, sir. It did not come. Now it is measuring the 21. No, no, 18, 18. Now it's measuring the 18.
If I have to see open it, I can see.
So you want to reinsert again?
Not really, sir. I want to do, sir.
Oh.
I'll see the participation.
Okay.
before closing, can you do a CM, sir? If in case.
Now, what is the issue, Pragya, mainly?
So from what we can see is when the software sends electrode through the through one electrode, it measures the response from the other electrode. When it feels that there is some obstruction of the current passing through, it sends a high current through that electrode to break away that barrier. But that it has not been able to do that for the basal electrodes, which means that there is some kind of barrier.
हो गया,
There's
इसका
some
नहीं आया।
barrier around the electrode.
इसका नहीं आया, हो गया इस NRT is done, but we could not get an NRT for the basal electrodes.
First 5 electrodes. Right?
Yeah, the first 5
Can you
electrodes.
see the first 5 electrode?
Yes. Most probably, since the insertion was smooth, there should not be any kinking or anything of the electrodes. But just to be sure, I think we can do a CM before complete closure, sir. What do you recommend? Thank you, Fukan sir, for joining us and adding to the valuable discussion. Hope to see you again during the 50th surgery. So, are you preparing for the X-ray? What is going on right now?
This is the outer mark. This is the inner mark. The inner mark going to be just at the rock. See, this is the first mark. Check them with shortest. Just hold on. Yes, yes, yes. Yes, we just checking the electrode. Now, you will be lucky for that. Okay, mark to the
They are checking the electrode. So we have to do an activity. So we adjust the and this I'll close the software and reopen again. No? Close actually. Yeah. We'll measure again. You can see my let's start now. Okay, okay. Started.
I think you can also just select the first basal electrodes, basal 5 electrodes, same time, instead of measuring all the electrodes again.
Not came. It did not come for the first electrode. Now it's, sir? So the first electrode we checked, it did not come. Now it's 11 we got. Now it's measuring the 16 one. The first electrode, it did not come. We had problem in the first 5 electrodes. The rest also, it came also, now it's coming also.
So
First 5.
Rosina, what you can do is you can select the first 5 electrode and measure only in those, because we got responses
Okay.
from the other electrodes.
Okay. I'll stop in between. You want to skip this electrode? Yes.
Close that.
You have to go here.
Yeah.
Okay, we want the first 5, right?
Yes.
Okay, I'll remove all this.
And
I'll just take the first 5 only. First two is already done, so I'll not take. Second to 5.
And just see if you can increase the pulse width in the general settings. Is there an option?
No. We have stimulation rate, current level, and sweeps. Pulse width, we don't have the option to increase or decrease here.
Okay, it's all right.
Yeah. Okay, let's start. The authority is out of compliance. Okay.
We are getting response at 5th electrode. Previously, we did not get. So we at least know that it's not a permanent damage to the electrode or anything. It's most probably air bubble or some kind of blood around the electrode contact, which was causing the issue. And hopefully it should resolve with time.
So it is going on for third one. Sorry, fourth one.
Yes, we are getting.
Yeah, we will get, yes.
And the thresholds are also pretty low.
Yeah.
So good news. I think we got open circuit.
We got
4th and 5th electrode, right?
Yeah, now we got 4th and 5th now, but the first 3 electrode we did not get.
Okay, can you just quickly measure the impedances once again? I think the impedances should be fine now in 4th and 5th electrode. Impedances. Yes. Measure impedance. Save this. Go to the threshold. So,
Oh, sorry. What did I do? I click on by mistake. I click on the pen.
It's okay.
Okay, let's measure the impedance. Okay, and now so impedance measurement is going on. Okay, now the open circuit is coming at third electrode. Now we check the impedance measurement. Now only third. Initially it was 4th and 5th. Now it's on third. Precision हो रहा है. Okay, I'll save this. It's not coming. Saving option. Okay. Save.
it's saved already. Just go to threshold profiles once. Show threshold profile. Okay, the last measurement did not get. Select last 5 measurements.
Okay, the latest one did not get saved, so it's all right. I think yes, we can do it post-operatively. It's okay. It's okay. I think you can close it. So I think the good thing is that now we know that there is no, it's not a permanent issue. It's not a long-term permanent issue. It's a temporary issue, which is probably because of obstruction around the electrode contact. You can close session. Close session on the left side. Close the session on the left side. Go below. Down, 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 down. Not there. Yeah. Yeah, right there. Yes. So, Counselor, can you hear me? Hello? Hello?
Yes, I can hear you.
Sir, so I mean, I think now we can almost assume that there is probably some amount of fluid or like blood clot or an air bubble. If there
Yes,
is
yes.
that in the cochlear lumen, is there any risk apart from impedance issues in the electrode? Is there any other risk?
See, there's not, I don't think there's any chance of air entering because that should not be the cause because we have not sucked out the entire endolymph or something like that. So
Okay.
there's no question of air entering because already there's something which is occupying the space. The it is only it must have been only a little bit of one, maybe a very small amount, a very small drop of blood that has gone in because Biswa was drilling a little more than usual on the lip area.
Okay.
When he was doing the extended round window approach, normally we drill a little bit, he was drilling a little more. I think complete confidence, maybe overconfidence also sometimes. So he was drilling a little more because the exposure was good in this case.
Right.
You are getting a good space, so he was trying to get a. So while the drilling was going on, you need just a very minuscule actually amount to cause an impedance, isn't it?
Correct, correct, sir.
Very minuscule because it will act like an insulating agent for preventing the electrical signals from going in.
Correct, correct, sir.
So, and that is what Biswas also rang me up because they also had some issues in their hospital also in GMC, similar to what we had in the beginning. When we are very sure about the insertion, there is no doubt about anatomical that it's gone in the proper place. I think there is no other reason, and
yes,
I think that is the only thing. And regarding to your answer to your question regarding what else can happen, I don't think anything else can happen because it's not a massive blood content in the inner ear.
Okay, okay.
Okay, Biswa says that let us close the session then.
All right.
Okay.
Okay. Thank you very much. Thank you, everyone, whoever has joined us today. And thank you, Rosina, for a great clinical presentation as well as the intra-op session. Thank you, Sanchita Ba, for a very comprehensive and very detailed radiological session. Thank you, Viswajit sir, for giving us this very nice, smooth view of the entire surgical process. And thank you to the whole team for letting us view the ESRT for the first time. That was very exciting for us. Thank you, Counselor, for answering all our questions, for participating so actively in the discussion. Thank you, Mansi, also, even though she's not feeling well, she contributed very well to the discussion today. So thank you, everyone, and let's keep our fingers crossed for the switch on for the further hearing journey of this child. And we'll see you again during the 50th surgery, hopefully soon. And thank you. Take care. Goodbye.